Good evening, everyone. Thank you so much for joining us for the Journey to Health Equity, Creating a Diverse Nursing Workforce Nursing Virtual Conference. My name is Deborah Stamps. I'm the founder and CEO of Deborah Stamps Consulting and the New York State Action Coalition co-lead, along with my colleague, Deborah Elliott. And we're really pleased to see all of you. I'd like to thank all of our amazing sponsors and schools of nursing that helped to bring this program to fruition, along with all of our planners, our sponsors and schools of nursing, the Union School of Nursing. We have Mercy University School of Nursing, Columbia University, the New York Organization for Nursing Leadership, Georgetown University, the New York Nurses Association, American Chi Chi chapter of Chi Phi Sorority Incorporated, the Future of Nursing Action Coalition, and Deborah Stamps Consulting. I'd also like to thank each of the faculty and deans for their support. Dr. Kenya Beard from Mercy University, Dr. Roberta Waite from Georgetown University, Dr. Kelly Bryant for Columbia University, Dr. Ashley Perel Graham from Columbia University, and Dr. Rebecca O'Connor from the University of Washington School of Nursing. We have an amazing student panel that you will hear from a little bit later on this evening. At this time, I'd like to have a land acknowledgement from Ronalyn Pollock. Just to introduce you to Ronnie, she likes to be called. Ronnie Pollock has previously served as the executive director of the Native American Cultural Center in Rochester, New York. Prior to her time at the Native American Cultural Center, she worked as a forgiveness coach, utilizing the healing power of forgiveness to transform lives while incorporating the 7 generations principle into her work. Currently, Ronnie is the Director of Training and Community Engagement for the Center for Dispute Settlement. She is also an adjunct professor at Monroe Community College and has taught in the Health and Physical Education Department for over 14 years. Her background also includes being a holistic health coach while having 12 plus years of experience as a social worker in the early part of her career. Ronnie is a member of the Mississaugas of the Credit First Nation, 6 Nations of the Grand River in Ontario, Canada, but currently resides in Rochester, New York. Working with Indigenous peoples in the areas of forgiveness is something that is sacred and personal to her heart, as she desires to see all nations heal. Please join me in welcoming Ronnie Pollock.
Yahweh, thank you, Deb. I appreciate that. Sego Seguego, Ronnie Pollock Ingots, Nuya Nuya. Hello, everyone. My name is Ronnie Pollock. Happy New Year. I will offer tonight's land acknowledgement, but before I do so, I just want to take a moment and thank Deborah Stamps for taking the time to take the lead and take the charge and start out each one of our conferences with a land acknowledgement. It's significant, it's important to honor the land in which we are on and the connection that we have to the land as well. At the same time and in the same respect, we're also offering our honor to the original people of the land and also to the ancestors and everything that they have left behind for us to be here now in today's present day. So thank you so much for your intentionality, Deb, in doing this land acknowledgement and starting out this way. So tonight's land acknowledgement, because I'm coming to you from Rochester, New York, I am honoring the land in which I am on and I am from. I believe as well as Deborah Stamps, and I think many of you have indicated in the chat that you may be from the area as well. If you happen to be from another area, I would certainly encourage you to look up whomever it is whose ancestral lands that you happen to be on. It should just be as simple as a quick, easy Google search for you to find out that information and to kind of keep that in mind moving forward, before a gathering, before a meeting, just to take a moment and give reverence and honor to the land and more importantly, to the original people of that land as well. So we would like to acknowledge the Seneca people who are the traditional custodians of the land that we are on and for their enduring presence. We would also like to pay respects to elders past and present of the Haudenosaunee Confederacy, and we extend that respect to any other Indigenous people who are present with us today. We make this acknowledgement as a first step in fulfilling our responsibility to critically look at colonial histories and their present day implications as we pay respect to the keepers of the land and the land itself. We are aware that acknowledgement is not reparation, and land acknowledgement without active steps towards education, support of the Seneca Nation, and sincere efforts to undo colonial legacies means very little. I want to end with saying this land acknowledgement is not meant to be an empty gesture, because without action, land acknowledgements run risk of becoming performance-based and empty calls to action. Nyaweh, thank you.
Thank you so much, Ronnie. Really appreciate the partnership, and I learned so much from you in the work that we have ahead of us as we continue to partner with our Indigenous populations. I'd like to also recognize Jalen Webb from Webistry LLC, who is our technology support extraordinaire. She is amazing. She is working behind the scenes to make sure that we have the smoothness of transitions. I also want to thank Beta Chi Chi of Rochester, New York, Chi Phi Sorority Incorporated for providing the C&Es for this program this evening. I do need to read this disclosure statement for nursing education credits. Chi Phi Sorority Incorporated is an approved provider of nursing continuing professional development by the American Nurses Program, will award 3.0 continuing nursing education credits. Criteria for awarding the nursing continuing professional development credits is that an attendee to receive the nursing continuing professional development credits, you must comply with the following: sign in and be counted virtually by your given name, remain for 90% of the presentation, and complete and submit the presentation evaluation form within the designated allotted time. We will have the evaluations available after each speaker. We know that some people may not be able to stay the entire time. We hope you do. So you would actually receive 3 separate certificates tonight. The presenters and the speakers and the members of the planning committee have declared no conflicts of interest, and there's no activity that has commercial support or sponsorship. It is my pleasure to introduce our next speaker, Dr. Kenya Beard. She will speak to us this evening on the topic of health equity, a reality or a dream deferred. Dr. Kenya Beard is the inaugural Dean and Chief Nursing Officer at Mercy University School of Nursing and the past chair of the New York State Board for Nursing. As a 2012 Macy Faculty Scholar committed to strengthening workforce diversity and advancing health equity, she founded the Center for Multicultural Education and Health Disparities and propagated research that best practices to improve health outcomes. She later served as a senior fellow at the Center for Health Policy and Media Engagement and co-produced healthcare disparity segments on WBAI-FM, which provided information for more than 400,000 listeners. 400,000. More recently, she co-authored and established the nation's first Nurse Faculty Fellows program. Dr. Beard's diversity efforts span over 30 years and resulted in her being invited to co-create the Josiah Macy Foundation's 2018 groundbreaking document, Improving the Environment for Learning in the Health Professions. Dr. Beard is an innovative thought leader who has never withdrawn from the challenge of mitigating disparities in healthcare. She co-authored the Commission to Address Racism in Nursing's 2022 foundational report titled Racism in Nursing, and continues to serve as a commissioner. Her discourse, Leading in a Race-Conscious Society, is supported by the Harvard Macy's Institute's Program for Educators in Health Professions. To address racism in research, she co-authored the National Academy of Medicine's Perspectives, Dismantling Systemic Racism and Advancing Health Equity Throughout Research. She recently co-edited the Future of Nursing 2020-2030 Global Applications to Advance Health Equity book to support the operationalization of health equity. Whether consulting with schools on designing a multicultural curriculum, leading a multi-million-dollar workforce diversity grant, serving as a reviewer for the Future of Nursing's 2020-2030 report, co-creating the New York State Action Coalition's Diversity and Inclusion Toolkit for New York State, or advancing equity as an advisory board member for the New York Academy of Medicine's Health Equity Scholars. She has continuously amplified the ideals of DEI and its role in improving health outcomes. She serves on the editorial board of the American Journal of Nursing and is a fellow of the New York Academy of Medicine and the American Academy of Nursing and the Academy of Nursing Education. Please join me in welcoming Dr. Kenya Beard.
Thank you, Dr. Stamps. Good evening, nurse colleagues, my friends. What an honor it is to join you tonight to discuss how we can advance health equity. It's a difficult topic, right? Health equity is the right for everyone to achieve their highest level of health. And it sounds so simple, but every day that right is being denied to so many people. And what can we do as nurses to address that? But first, let me thank the conference planners for making tonight possible. Thank you, Deb Stamps. So many have volunteered on our behalf to create tonight's webinar. And to all of you, your evening, allowing us to come into your homes or your offices. Thank you, thank you, thank you for all that you do to improve healthcare outcomes. I want to start tonight by sharing a story about a young lady, and we're going to call her Liz for the rest of the evening. So Liz is a young African-American lady who was 24 weeks pregnant, and she was admitted to the hospital with a vaginal bleed. And knowing what we know about maternal mortality in the United States, when we hear that someone who's African-American, 24 weeks, vaginal bleed, we can get a little nervous about that. So this person, I actually knew her. So I called her when she was admitted and I said, what are they doing? What do they believe is the cause of the bleed? And she said she was given steroid injections and that her iron level was very, very low. And that the nurse came in and shared with her that she needed to take an oral iron supplement, but she said she didn't want to take it because it made her nauseous. And she said, the nurse said, oh, I totally understand, and didn't give it to her. Didn't tell her why she needed it, why it was so important, just said, oh, it makes you nauseous. Okay, you don't have to take it. Her blood pressure was very low and she came in with dizziness, and the doctor told her she had to be on bed rest. And she said to the nurse, I just feel like I need to take a shower from the bleeding. Could I just take a shower? The doctor said, no, but I'll make it quick. And the nurse actually said to her, go ahead, I won't tell anyone that you took a shower. She also told her that her dizziness was because she was anemic, but she didn't understand that. So I asked her a lot of questions that she started to get frustrated about. I don't know much about maternal health. That's not my specialty. I'm adult Jerry. So I called one of my colleagues, Rewa Thompson, Dr. Rewa Thompson, who's a maternal health expert and OBGYN. And I said, can you do a three-way on this call? And let's hear if they're, practicing best standards of care. And unfortunately, all the questions that we asked Liz, and she wasn't able to answer them, you could tell she was starting to get frustrated. So we stopped the call, we ended it. And I said, I'm gonna call you back later. Let me know when your doctor comes in. I wanna speak to the doctor. Unbeknownst to us at the time, a nurse came in after our call. And she said to the nurse, two people, she just got off the phone with them. They were asking her all these questions. And then all of a sudden she started crying, she said. She was crying hysterically. And she said to the nurse, I'm a lawyer and I'm trained to be objective. And the person I was speaking to, she's a national expert on healthcare disparities and maternal mortality, the other nurse that I spoke to. And they were asking me all these questions about my care. And I just don't know what's going on. Well, with that, what do you think happened? The nurse immediately ran out. And within 15 minutes, every doctor you can think of was in the room. They were appalled that she didn't have an IV started yet. With the low blood pressure and dizziness and bleeding. So an IV was immediately started. Another doctor came in and said, who ordered oral iron? You are so low, it will take 6 months with oral iron. You need IV iron. So they started that. There were a lot of things that happened after the fact. But why did it take her telling them that she was a lawyer, even though she looks like she's 16, right? And she looks like she just very young. So I'm wondering what the biases were about her. And then when she told them who she knew, all of a sudden her care was different. We've got to think about how that happens. All of us are wired with biases, right? Um, and when we're racing all day, acute care settings, we're anxious, we're stressed, our implicit biases can operate. But what impact is that having on patient outcomes? I started nursing school in the 80s. My colleague, Dr. Stedman's on the call. I think she was in the 70s, and she can attest later or put it in the chat box. Back then, we were trained to really focus on patients and say, you know, if you just listen to me, I'm going to help you get better. If you do this, if you have diabetes, if you have this, if you have hypertension, just do these things and you'll have the best outcomes, right? We did motivational cueing and all these great things, but the focus was on patients. And then in the 90s, we said, you know what? The Institute of Medicine came out with Crossing the Quality Chasm. They came out with To Err is Human. And we started thinking, wait a second, it's not just the patient we need to focus on, it's the system. Medical errors are occurring because the systems need to be designed in a way where we are working as a team and we're not. Okay, so we focused in the 90s on systems. But then in 2004, the Institute of Medicine came out with the report, Unequal Treatment. And I remember reading that report saying, oh my gosh, if my grandfather was still alive, he would have said, I told you, and you didn't want to listen to me. You went to nursing school, and all of a sudden now you want to tell me what I know to be true, but you want to tell me a different reality. And my grandfather, growing up in the South, being around the Tuskegee experiment, not trusting healthcare providers, when he was retired and he was picking up stray dogs for volunteer work with the town, and he thought he had pulled a muscle because he picked up a dog, but the pain never got better. So I said to my grandmother, if he's still in that much pain, he has to see a provider. And he was resistant. No, I'm not going to see a provider because they're going to give me something that's going to make me sick. Well, you know why most people end up in the ER, because they have pain and they want that pain to go away. Well, the pain got really, really bad and he went to the ER. But by the time he got there, they told him he had 2 months to live. He had lung cancer, it had metastasized, and he died in a month. But I remember saying to him, no, I'm in healthcare. I'm telling you, Grandpa, my colleagues would not do anything to harm you. Boy, was I naive coming into nursing at the age of 19 and then reading Unequal Treatment, where all of these studies that were conducted showing, yeah, we do treat people differently. And then in 2007, the VA study that came out, and I'm thinking the VA, my husband's in the Marines, and I'm thinking differently about healthcare outcomes. And the VA study said, we did a retrospective study, and it wasn't looking for causation. It was just saying, do we treat people differently? And they looked at Black male veterans and they looked at white male veterans, and they said, wow, we withhold treatment or withhold information to the Black male veterans. We don't treat them the same way we treat white male veterans when they come in with osteoarthritis. We give white male veterans narcotics for their pain, and for Black men, we don't, right? So this was a study that when the VA shared all of this and they said, we don't know why, we can't tell you why, that wasn't the focus of the study, but we're going to try to find out why. And the studies that have subsequently come out showing that we still have a population of individuals in our country healthcare providers who believe that if you are Black, your pain receptors are deeper and that you wouldn't feel pain the same way. that someone who was not African American. And that was a hard pill for me to swallow because I thought some of those myths were buried many decades ago. But I say all that to say, and I want to stay on track because Deb is going to say, you don't have all this time. So when she shared the story, in September, she delivered a beautiful baby girl. So when we think about infant mortality, she was fine, no problem. But we have to understand that while they were fortunate, the reality is that not everyone's narrative ends with a smile. And for some families, preventable deaths are their reality. And as nurses, medical errors, they have an impact on us. And while infant mortality rates have declined, we can see with this map that not all states can celebrate. So why are studies revealing that infants identified as Black are at the highest risk of dying within less than 28 days, or that they're suffering morbidity? Does race matter? Does the degree of melanin predict outcomes? And should it predict outcomes? So we know that race is a social construct. It is not a biological factor. And when we use it as a predictor, we obfuscate some of the upstream factors that really contribute to healthcare disparities. And race becomes like this thick, heavy fog that covers the real upstream causes of disparities and allows disparities to continue despite all the hard work and billions of dollars that are spent to mitigate it. So how do you, as a nurse, tackle what's invisible, these upstream factors? So first, no, thank you. First, appreciate that we as nurses, we can do more. We need to first understand the difference between equality and equity. And as nurses, that should be a feel-good statement, because when we think about what we do as nurses, we treat how patients respond, and we train new students coming in to be able to treat and address the needs of patients, and to really focus on giving people what they need. Equality is everyone gets an equal share. So it doesn't matter if I had a BMI of 30 and you had a BMI of 20, if I have an apple pie, you get 50%, I get 50%. If I have a BMI of 30, I'm high risk for diabetes, type 2. We all know that. I probably shouldn't eat half the pie, but that's equality, right? You get it even if it's going to harm you. Equity, everyone, we meet them at their level of need. We see what their needs are and we address it, and we give them resources that make it an equitable playing field. So tonight, in the few minutes that we have, let's talk about some of the upstream factors and how we can reduce the gulf between healthcare disparities and health equity and what it looks like. So this is a diagram that I usually share with colleagues, and I ask them, how do we move from healthcare disparities to health equity? We know Healthy People, when it first came out, 1979, Healthy People was saying, we've got to mitigate healthcare disparities. Around 2001, 2, we started using health equity. That language came into play. And we said, let's not just focus on healthcare disparities. Let's talk about how everyone should have a right to achieve their highest level of health. And how do we do that? So they said we have to be more diverse, we have to be more inclusive. But what is causing that gulf? I want you all to put in the chat box, and Deb, if you can help me, what do you think is preventing us from getting from the healthcare disparity side of the road to health equity? What are those factors? And Deb, just tell me what people are saying. What do they think are those barriers and those challenges that are serving as disruptors of health equity?
Implicit bias, biases, fear of change, systemic racism, denial, racism,
Racism,
knowledge,
fear, denial. Yeah.
incremental change, time, disregarding policy, not enough knowledge, exploitation, mistrust, money, financial,
So yes,
unconscious
yes,
bias.
yes, and yes.
Mhm.
All of those answers are spot on. So we
Poverty.
could actually see how implicit bias, structural racism, unconscious bias, right? Implicit bias, how resources, not having enough, how social determinants of health, all of these things can serve as a reason that's going to interrupt our ability to get towards health equity. So what do we do about it? Anyone want to put in the chat what, or come off of mute and share, just raise your hand if you have a comment. What do you think we should do? Everyone has shared such great factors that are stalling efforts to advance health equity. And our Future of Nursing Report, 2020-2030, our Nurse Essentials, all these
Education.
reports are saying we need to advance health equity. How do we do that?
Education, knowledge, educate, incorporate anti-racism, policy change, universal healthcare implementation,
Yeah.
incorporate anti-racist teachings throughout the lifespan, gain the knowledge
And
and
that's
share
definitely a start. Educate, 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 right? But education is
awareness.
not a panacea because many of us know what we should and should not be doing. And that doesn't mean we're going to change our behaviors, right? You could have someone who smokes, a nurse who smokes, knowing that they shouldn't be smoking. So education is not the end all be all, but it is the starting point, right? Because we hope when people know better, they do better, but we're all human. And
Accountability.
Accountability. So I asked this question at a conference and I said, do we focus on educating about implicit bias, structural racism? Where do we use our resources so we get the most bang for our buck? And a gentleman said, do you realize that we don't know how deep that gap is? And we could spend a lot of money and resources and time trying to fill that gap. And we might be stuck there forever. So do we build a bridge across it? And if we build a bridge across it, what's to stop that gap from getting bigger and that arrow extending, having to extend? So while we might not have all the answers, we do know that we need a strategic plan and we need a multidisciplinary approach to advancing health equity. So Georges Benjamin, he said, health equity is a goal we can all achieve. It's within our power to do so. We have the tools, we have the knowledge, but it's up to all of us to make it happen. And if we say it's going to happen and we do what we need to do, it can definitely happen.
Dr. Beard, there's one comment from Lakeisha Nichols that states, we can't educate away racism. Make reimbursement tied to health outcomes for populations that have poor outcomes related to care.
Great comment, great comment. And someone said earlier, Deb, to that point, accountability, right? We know when I came into nursing, it was retrospective payments, right? You go into the hospital, you stay 30 days after you have a heart attack and you have a cabbage. That was my experience. And then in the 90s, they did prospective payment and they said, no, we're not going to let you tell us it took 30 days to get this patient to goal. We're going to tell you how much we're going to pay. And if you go over that, there'll be a variance. You can submit reasons why, but this is what you're going to get. And now it's better if you get people out earlier, but to make a profit, it was difficult. And Deb, you can interrupt at any time because you were a chief nursing officer. You know this better than I do. But now we're saying you got to pay for quality, right? And that's new. So now hospitals are getting dinged. If patient satisfaction scores are not where they need to be, providers are like, we're paying for quality care. And some will argue, yes, that's good, but there's always unintentional consequences for everything, for every step of the way, right? So what do? Well, we understand healthcare disparities. These are differences in the quality of healthcare. We need to understand they are not due to access, right? When we think about healthcare outcomes and healthcare disparities, we have to think about access and the quality of care. And the Agency for Healthcare Research and Quality, AHRQ, every year they come out with a report and they're saying that the quality of care is different for people in poverty. And that was a hard pill for me to swallow. But I had to understand that when a person is in poverty and they present in a way, let's say a person's homeless, and they present in a way where the socks are not clean, our nurses do, and they're diabetic, and we know we have to screen them every year, do a foot screen assessment. Are we doing that assessment? Are we taking the shoes off? And some of us will say, of course we are, but the literature is saying, no, we're not. The studies are showing people are not getting these screens done. Is bias playing a role in that? Right? So I had to think, would I treat someone who is homeless differently? And the reason why I had to think long and hard about that, because as nurses, we're like, I would automatically say absolutely not, right? When unequal treatment came out and they said African-American women, if they go into the emergency room with chest pain, so I'm thinking myself in my 50s going into the emergency room with chest pain, chances are I'm gonna be treated less aggressively. So I went to all my colleagues and like, would you treat me less aggressively if I came into the ER? And what did they say? Absolutely not, Kenya. So if someone asks me, would you treat somebody who's homeless differently? I would say absolutely not, even though the studies are saying we are. So it takes a degree of humility to swallow that, right? I remember when I used to work in the city in Manhattan, and before my dad died, he would always, when I was out, he was just very excited that I was in nursing school at Beth Israel. And he'd come into the city, take me to dinner. He'd always give homeless people $1. One day, this man is stumbling, he's moving back and forth, he looks to me inebriated, and my dad gives him $1. And I'm like, oh, and I pull his arm back and I'm like, what are you doing? Don't give him $1. He's just gonna go to the liquor store and spend it there. And my dad, in a very deep Barry White voice, said, don't do that. And I got scared, so I didn't say anything. But in my head, I was thinking, don't do what? Save money? So as this 17-year-old, very naive, and very judgmental individual, I was like, oh my gosh, I can't believe he's giving him $1. But I found when my dad died of a massive heart attack, I found when I went into the city years later, I would always make sure I had $1 in my pocket to give to someone who was homeless. And I said I wasn't going to judge. I was going to do what my dad did. And whenever I did that, I just felt closer to him spiritually, and it made me feel good. And one day I come out of Penn Station, there's this man with a cup out, he's got gloves on with his fingertips, the cut out with the gloves, so I could see his fingers. And I put $1 in his cup, and you'd have thought I gave him $1 million. He was like, thank you, thank you. He extended his hand. I looked down, I saw black in his fingernails. What were my biases? I can't tell you at the exact moment, because I had what they call like a panic attack. And I saw him saying like he wanted to shake my hand, and I ran. And when I got to the end of 7th Avenue, I was like, what did I just do? Here I was trying to make someone feel good. And if I went back, he probably would have said, take your $1, lady, I don't need it. You think you can judge me? I felt horrible. So I get to work. One of my colleagues, psych mental health nurse practitioner, I was like, Claudia, I feel horrible. Oh my gosh, what did I do? And she was like, Kenya, your amygdala got hijacked. I said, what? She was like, your amygdala got hijacked. You got scared. You were an infection control nurse. You thought you were going to get something. It's like very defensive.
Okay.
I said, no, I didn't. I didn't feel like, and then I had to just take a moment and think about what happened. And then say, if I was working in a clinic caring for homeless people, would I make up the statistics of providers who fail to do those foot exams on diabetics and thinking somebody else will take the shoe off and the socks off the next time they come in? I don't know. But what I do know is we need to have these conversations, and it takes a great deal of humility. And someone said before, when we talked about the chasm, that the fear and people in denial, we have to realize that this is the way our brains are created. Biases are not something that some people have and some people don't, right? If you're walking outside and a big black grizzly bear comes walking toward you, you're not going to go up to it and say, oh, let me see if it has an ID tag and find the rightful owner. No, even if you weren't born in the generation with Reader's Digest and you read all these articles about bears killing people, mauling them, you still have a belief about bears, beliefs, attitudes that will shape how you respond when you encounter them. If your amygdala gets hijacked and you are scared, your fight or flight system gets activated, you act differently. We've got to accept that. And what the scientists are saying is that when we are in acute care settings or settings where we're feeling rushed or anxious or scared, our implicit biases come out. And sometimes we don't even realize we have them. So when we think about healthcare disparities, right? Patient factors, institutional factors, provider factors, unequal treatment made us realize that we can't just think about the patient. We can't just think about institutions. We've got to look in the mirror. And we really never really did that as a group. So when I think about this study, and they said that non-Hispanic Black infants compared with non-Hispanic white infants have twice the risk of death in the first year. And it's particularly striking because Black infants only make up 15% of all births, but accounting for 29% of the deaths. Our textbooks are teaching our students that race is biology. So when we think about the upstream factors, those factors that look up the stream, go around the bend, go to a place that you cannot see, those are the upstream factors that we need to talk about and bring them into conversations. Social determinants of health. We have to also talk about implicit bias and definitely structural racism. Ouch, it's hard to talk about racism. The Nursing Essentials is saying now in classes, educators have to have conversations about racism. I have a lot of colleagues that are saying, I am not going near it. I can relate. Because when we first started saying, you've got to talk about LGBTQ, I was like, absolutely not. I'm not talking about that in the classroom. I was not trained to talk about that in the classroom. And if I say the wrong thing, I am going to get slammed. I'll take a pass. And they said, no, Kenya, you can't take a pass. We are going to teach you how to have these conversations because there are some groups that do not want to go and get healthcare, get any healthcare because they're afraid that they're going to be stereotyped. And we need to have these conversations. So I get it. It's difficult. So when we talk about these upstream factors, the conditions in which an individual is born, implicit bias, we talked about that already, what the definition is, and structural racism, the differential access to goods. I know that when we're talking about racism, it's hard. And I did a study with my colleague a couple of years ago. Did racism really exist in nursing? We found out, yes. A lot of colleagues were saying, oh my goodness, yes, I've been exposed to racism. I have a degree. I am a nurse practitioner. I'm more credentialed and qualified to teach in the NP program, but I've been relegated to the undergraduate program where people who aren't credentialed, don't have the degree, and they're not even nurse practitioners are teaching in the NP program. So we can debate, well, is that racism all day long? But remember, we're talking about someone's lived experience. And my responsibility is not to argue someone's reality, but to come and listen and try to understand their reality and not argue it. So I love the fact that med students at Brown University came out years later with an article and they challenged the educators. They were like, you guys are teaching us race and racism. You're teaching us that race is a biological construct and it is not. And we are demanding that you change the curriculum. And Brown University, the progressive school that it is, they changed the curriculum. And I was really shocked because when I thought about racism, I thought about or implicit bias. I thought about people who were homeless, people who were in poverty, people who were in minoritized groups. I did not think about NICU patients until I read this article. And it said that even in neonatal intensive care units, There's bias and we treat babies differently. So I called my colleague from Rush, Renita Julian, who's a NICU specialist, and I said, is this true? Please, read this article. And she said, why would you think we would be any different? We all have biases. We've got to stop thinking that we're going to find or encounter someone who doesn't, because it's how our brains are conditioned. So I was very fortunate to take part in the commission's work to address racism in nursing. And they too, more recently, 2 years ago, did a study and found that, yeah, racism is still existing. And when I think about bias and how this lawyer who said, oh my goodness, she writes this article for the New York Times, you look at the image, right? You see on one side, a child is holding their head, they bump their head, they're crying, they get a Band-Aid, the mom's holding her, and it looks like there's empathy for this child who's injured. But you see on the right side, this child being taken away, and the mother aghast, and someone pointing their finger at the mother. So the lawyer was saying in this article, why is it that my Black and Latino clients are accused of abuse when their kids have accidents? She makes a living off of this, getting children back to their parents. Can you imagine? And I thought about, wow, I have a son who, he didn't think about walking down the steps one at a time. It was always 4 steps at a time. So if I brought him to the ER, would they think, because of my color, that I'm negligent? We've got to remember, bias is everywhere. What are we doing about it? Are we having these conversations in the classroom? So some of the reasons why we have disparities, we see this study that was done in 2017, infants identified as Black were more likely to have nursing care missed in their NICU stay. And what was really complicated about this was that they said nurses in hospitals with 1/3 or more % Black infants miss 50% more nursing care than those in hospitals with less than 1/10% Black infants. And that wasn't just by itself. They added that nurses cared for a significantly higher, so their ratio was higher in hospitals with a high Black infant population. And that care was missed. And we think about that VA study, care was missed, such as teaching and counseling, same thing, the other NICU study showed in California, preparation for discharge, addressing parents' capabilities and readiness. So we need to make sure we change the narrative, and I'm going to end with this. Structural racism we've got to think about the ways in which it fuels disparities. Racism induces stress. We know that. We have tons of articles that talk about the effect that racism has on cortisol levels. And as nurses, we know that cortisol can raise your blood sugar, can raise your blood pressure. So and that's for the geriatric and the elderly population, right, that I'm thinking about. But I'm also thinking for this population, neonates, how high cortisol levels and maternal health can restrict blood flow to the placenta, stunt growth, trigger labor. Are we having that conversation in the classroom? So as all of you on the call, you are nurse influencers. You have the power to influence health equity. 3 things I want you to do. Recognize first that race is not biology. Contextualize information, and I know that's hard. And interrupt bias and false narratives. How are you going to do that? When you see this question that was in a textbook, this was a question for students, the most important factor for the nurse to consider in assessing a mother's risk of having a low birth weight infant. This is perpetuating disparities and perpetuating false narratives. African-American race should not be one of these choices. We've got to stop using race as a biological construct in our exams. That's number 1. We also have to contextualize things. These are things that I've seen in the textbook. I copied and pasted. Obesity rates are highest among African-American women, and they have the lowest rate of breastfeeding initiation, shortest duration. They don't talk about how people from minoritized groups are more likely to come to experience poverty. And people who are in poverty, they don't have the ability to stay home for 6 months. And the breastfeeding might be different for them because of different factors. Don't equate the color of their skin or their BMI for the reason, right? You see correlations, but correlation is not causation. We need to start talking about the causes and include racism, social determinants of health, and implicit bias as some of these causative factors. I know it's almost time, Deb, I'm wrapping up. So the courage is the last thing. So we're not going to talk about race as a biological factor. We're going to contextualize information, and we're going to have the courage to interrupt bias. This is probably the hardest thing to do, I know, because I've been facilitating race-related conversations for about a decade now. And I was appalled and shocked when I read this article. This article, I'm an editor for HAN. It was in HAN. I read it and I was like, what? Factors contributing to the rise of congenital syphilis in the United States. Black populations 3 to 6 times higher than among white populations. And I just said, man, we are just perpetuating stereotypes. I can see it now. Everybody thinks that all Black people have syphilis. This is just freaking great. And this is so not true. So I immediately, because I knew the literature, but I said, let me go back and look again. Maybe things have changed. And of course, the CDC showed that many more white people in the country have syphilis than Black people. But that's not reported here, right? That's part of the narrative that we don't share. And that has an impact, because if this author would have added that white people make up the most amount of people with syphilis, it tends to make the Black population being more at risk take on a different meaning. So I admit I was upset. So when you're upset, what do? You write a letter, right? Or if you're from my generation, you write a letter. Younger generation, they go on social media. But I wrote a letter, right? So I write a letter to the editor and I said, thanks for sharing the startling statistics. Can you see how highlighting risk factors and directly following it with the statement that the rate of reported cases, blah, 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 about Blacks is racially misleading and perpetuates stereotypes? Could you consider including that whites comprise the largest number of syphilis cases and contextualizing race? Because that will help destigmatize STIs, and it will reduce the risk of seeing certain groups through a lens of a negative stereotype. So I wrote the letter and I waited. And 2 weeks later, I got a response. And you're scared because you don't know how it's going to land. And you don't want to be antagonistic because, my goodness, the message is we've got to tell people syphilis is on, congenital syphilis is on the rise. That's the bigger picture here. And we don't want to miss that message. They were so deeply understanding. I love the editor, Carl Curtin. He was like, Kenya, I love this. Can we put it as an editorial response and put it in? I was like, no, this is between me and you. I don't want this out there. And he said, why? And I'm like, oh. And I remember having a conversation with my husband. And he says, so much for having the courage to talk about and interrupt bias. And I was like, yeah, but I don't want to put it out there because, it requires a longer conversation. And when you put sound bites out, people can misinterpret it. And then it takes on a whole different meaning. And I just didn't want to go down that slippery slope. But after speaking to my husband and Carl, Dr. Curtin, I said, go ahead. You could put my response out there. And it landed, thank you. It landed in a good place, but I was scared. So I understand when you say, oh, Kenya, you asked me to talk about racism in a classroom. I don't want to do that. Look, I've been doing this for years and I was scared. But we need to come together to make this happen. And I want to end with just saying every individual, that's the overarching purpose, right? I had to think about congenital syphilis. We got to get the message out there. That's the overarching purpose. So that has to help me, assuage some of the fear that's associated with it. Every individual should have that opportunity. And advancing health equity really hinges on all of us, right? Write down one thing in the chat box that you will do to reduce that gulf. Don't point fingers, don't say what other people need to do. Let's think about what we are willing to do, right? A personal commitment, one thing we're willing to do to reduce the gulf. And Deb, if you can just shout out a couple of things that people are saying that they are willing to do to address healthcare disparities and advance health equity. And I want to thank you all.
There's a lot of great comments. Nurses have to have the hard conversations with their patients as well as their coworkers to best educate and advocate for their patients, regardless of their race, living situation, etc. At times, we have to be uncomfortable. We have to have uncomfortable discussions to bring about change. Be informed and inform. Speak up. Speak up and call it out. Be aware. Check my own biases and advocate for patients. Stay informed. Have those hard conversations. Be a speak up ally. Advocate. Have courageous conversations with staff and patients. Get this information into the curriculum. Teach the knowledge, don't hold on to it. From an educator perspective, ensure that the resources I use in my class do not perpetuate these stereotypes. Empower others. Be willing to call it out in all the arenas.
Thank you. So I want to thank everybody here first before we close. Thank you, because you're all nurse influencers. Each and every one of you can influence how we advance, the extent to which we advance health equity. And we can make it a reality and not a dream deferred. So thank you. If we have time for questions, Dr.
Yes.
Stamps?
Absolutely. Thank
Maybe
you
an aha
so much.
moment.
Thank you so much, Dr. Beard. Amazing, always, always, always. Is there anyone that would like to ask a question? A lot of great things. Use data to show where diversity gaps are in your nursing workforce and how this information can be used to help dismantling health disparities.
That's great. Did anyone have an aha moment or a pleasant surprise? Something that you don't agree with? It's really important. I don't want to create this kumbaya moment where all like saying yes, yes, yes. It's really important to have people disagree. And if you don't have anyone disagreeing with something, you probably don't have the right people in the space. Sarah.
Yeah, hi, thank you so much. I'm wondering about, the idea of moving from kind of a false sense of race as a biological reality to the understanding of race as a social construct. And, in my own learning, that's not, a new idea to me. Is something that I believe. But I'm just thinking, as an educator, I don't feel that I yet really have, the resources to pull together to bring that to students. So, in saying this, I realized like, okay, next step for me, that's my work to find those resources. But I just kind of wanted to put that on the table as a, maybe not even as a question, although certainly, it could be if you want to respond to that now. But I'm just thinking about that challenge of, how we bring that change in thinking to students and actually just to all of us, everyone that we interact with.
I love that question, Sarah. It takes the ability first to recognize on our exams when we use race, right? And say 35-year-old African American, why are we saying that? 25 Hispanic, why? Why are we framing it with race? It's getting to the point in our society with so many, an increase in interracial marriaging. You can't tell what everybody is, right? You can assume, but you can look at a person, and we're going to have more and more where someone might look white and say, I identify as Black. My mother's Black and my father's white, right? So why are we using this arbitrarily? Because we think because you phenotypically appear to be a certain race, But what impact does that have? We have to move away from that. If the Genome Project taught us anything, we know that all of us are more alike than we are different, right? So in the classroom, how do I push back on exams? How do I push back when I see it in a fundamentals textbook? When I see it in the Med-Surg textbook, and it leads with, if you have a patient who's African American or Hispanic, make sure you screen them for hypertension because they're more likely to have high blood pressure. That's an opportunity for me to say, what are the social determinants of health that are going to impact a person's risk for having high cortisol levels? How does structural racism play a fact in a person's having a high level of cortisol, which is going to also increase their risk for having high blood pressure? So I think your question is spot on, and I think we have to embrace the fact that our textbooks are outdated with this. They're getting better. They are trying. They are including different people at the table. I know when my son, maybe now so long ago, it's probably 4 years ago, when he was in college, his textbook, he came home and said, "Mom, I didn't know that being Black was a risk factor for having a low IQ." And I said, "Exactly, Sarah." My eyebrows raised at like 10 o'clock at night. "What do you say?" And he said, "Yeah, it's in my textbook." And I'm like, "What?" I'm like, "Show me your textbook." And sure enough, in his Intro to Psych textbook, in the chart, I took a picture of it. I was livid, and I didn't know how to Twitter, tweet, whatever. And I said to him, "I want this tweeted out. I want you to attach it to my friends. And this publishing company, shame on them for putting this in here, because every student who is in healthcare, right, who wants to become PT, OT, ST, RN, MD, they have to take Intro to Psych. So they are reading this. So I'm thinking, wow, if they're being conditioned to believe that the color of my skin puts me at risk for having a low IQ, then of course, if I come in for treatment, they're not giving me the information because their bias might be, she's not going to be able to understand it anyway. So I'm like, oh my gosh, this is horrible. So usually when I'm upset, I write a letter to the president, but for some reason, I guess because it was late at night, I did something out of character. And I don't like to shame people, but I did shame them, right? I put it on LinkedIn, on Twitter, and I was like, shame on, I didn't say the word shame, but I was like, look at Macmillan Publishing Company, blah, blah, blah. Well, the next morning, this was 10 o'clock at night. The next morning I go into work, there's an email in my inbox from Macmillan. And I'm like, oh, how did they find me? How do they know my email? What the heck? I'm calling my son. Did you put my email in there? Like, how did they know? They found me, and they were like totally apologetic. "We are so sorry. We're taking it out of the online edition. We don't know how this got in there." And I'm like, do you understand the implications of what you are saying? Like, it's not just a sorry. But I digressed. Is that Aisha or Asha?
Yeah, Asha, hi.
Asha.
Thank you.
Beautiful name.
Thank you for this excellent presentation. I loved it. So I'm the person that's coming from Canada, and one of the things that is happening in Canada, that's the conversation about racism is quite delayed, I think, compared to the conversation that's taken place in the United States for decades prior. So it's relatively new here, and the population, of course, that is the one that is most used as the exemplar for where we're racist is with our Indigenous population in Canada. And one of the things that I'm finding as an educator is that there are lots of people that people are genuine in their desire to seek truth and reconciliation, and to combat racism. But one of the things that I'm finding frequently is that people will use Indigenous case studies, Indigenous whatever, and they almost have fetishized the idea. They're using the Indigenous population as, look, they have this, as opposed to these are risk factors and the social determinants of health specifically. So I'm wondering, what are some strategies that we can use? I tend to really focus on the social determinants. We look at housing, poverty, access to food, water, etc. That will explain things, and it's not necessarily because of their race. But how do you convince other people, and how do you share that perspective, as opposed to, yes, you should have exemplars that are all about this race and that race and this race.
Yeah, great question. Great question. I think I got stuck on the how do we convince? How do we
Yeah.
share this knowledge, right? Because knowledge is power, but what people do with it, right? I can't control that.
True.
But we should be sharing this knowledge. And when I think about racism and the conversations that have to be had, the first thing we have to do is recognize. When I was invited to speak for the Future of Nursing Town Hall a few years ago, I talked about the fact that if you had a house that was abandoned, all the rooms, electricity pulled out the wall, no plumbing, no running water, and I said, Asha, you need to live here. But guess what? I'm gonna clean up one of the rooms. I'm gonna clean up the bedroom, and it's gonna look beautiful. But the rest of the house is a hot mess. That's like analogous to nursing or healthcare saying, let's clean up healthcare and forget about all the other systems, the criminal justice system, the housing system, employment. You can't. You have to look at those rooms in the house as a different system. And if you don't address all of the systems, it's not going to work. And that's how the social determinants of health come in. So how are we co-creating policies and strategies? Lisa, what's Lisa's last name in Connecticut? She did something a couple of years ago with the Campaign for Action in Connecticut, where she brought in people from housing, people from the criminal justice system, and nursing and healthcare, and they had a conversation about the social determinants of health, because they said we can't have this conversation in a silo.
I love that. Thank you very much.
Okay, yeah, so my recommendation would be to really think about partnering. Lisa Sundin, thank you. And thank you for everyone who's Brianna and everyone else who's so clearly articulated, we are one race, the human race, with the Human Genome Project.
Thank you. Dr. Beard, thank you so much for an amazing presentation as always. A lot of great dialogue. I think this is only the beginning. And I thank you very much for sharing your experiences and helping us to start thinking differently on how we can impact racism, the healthcare disparities.
Thanks for having me.
Thank you, thank you. Thank you. So this is the survey that you can take to complete the evaluation form. It was also put in the chat. We will also provide these towards the end of the session this evening. At this time, I'd like to bring our next speaker on, Dr. Ashley Graham. So our next presentation is The Arc of the Nursing Profession Leaning Towards Justice: How Nursing's History Can Shift Health Equity Forward. Dr. Ashley Graham Perrell. Dr. Ashley Graham Perrell is a registered nurse and is triple certified in medical surgical nursing, nursing professional development, and as a certified nurse educator. Prior to joining the faculty at Columbia University School of Nursing as the director of the Office of Diversity and Cultural Affairs and assistant professor, she worked as a clinical instructor at New York University Roy Myers College of Nursing and a clinical nurse educator in an acute hospital setting. Dr. Graham Perrell's research is centered on diversity and inclusivity in nursing, with a focus on its impact on the admission, retention, and success rates of diverse nursing students. Furthermore, her research investigates the historical impact of the training of Black women in nursing in New York City's Lincoln School for Nurses and the presence of healthcare disparities among African American communities. Please join me in welcoming Dr. Ashley Graham Perrell.
Thank you all for having me. Thank you, Dr. Stamps, for having me and the sponsors. It's a pleasure to be here. And I thank you all for sharing in this moment of learning and really stretching our capacities towards health equity. I also want to shout out my husband for cooking dinner tonight. We're having ramen noodles, but it eased up the time. So today we are going back to history, and this conversation, I believe, couples wonderfully with Dr. Beard's presentation. I first want to start out with this quote, and it's an insert from the American Medical Association from 1864 of what a nurse should be. So I want you to pay close attention to the words that are used. I want you to pay close attention to your reactions. The nurse should be of sound constitution, of good muscular strength, and of great power of endurance, capable of bearing up manfully under fatigue and loss of sleep. Should not be younger than 22 or older than 35. She should be literate, courageous, patient, temperate, punctual, cheerful, discreet, honest, sympathetic, refined, selfless, and devoted. She should be able to notice the character of the secretions and excretions and the changes in the patient's physical countenance. The nurse should be adept in the application of leeches, blisters, bandages, and other dressings. She should be proficient in the making up of beds, changing sheets, and handling patients exhausted by disease and injury. And this is the doctors telling us, nurses, who fits the grain. So I want you to pause for a second and really pay attention to your reactions. How's your body feeling? If you are a nurse, would you stand up to the grain of what they're saying we should be? And I'll look to the chat, right? Let's look at the age range, 22 to 35. And a few of us were like, well, I'm out. Let's look at the pronoun that is used, she. We'll talk about that a bit more. Let's look at the adjectives, just a magical person they described. And while it's not explicitly stated, the nurse should be white, and we're going to talk about that. So today I am sharing with you all my quote unquote baby. This is research that is very near and dear to me. Oops, I'm hearing some feedback. If you can kindly mute yourselves. This is on the research of the Lincoln School for Nurses of the Bronx, New York. Have we heard of Lincoln School for Nurses? I'm opening the chat. Want to be able to connect with you. Ooh, someone said no. That's the best thing you can tell an educator. Thank you. Wonderful. So I'm just going to share a little glimpse of the Lincoln School for Nurses, and I'm taking you back in time. It is connected to Lincoln Hospital in the Bronx, but this is the School of Nursing that was connected. So we'll learn a little bit more about that. Wonderful. As we discuss Lincoln School for Nurses and how this ties to health equity and why history is important, I want us to consider why diversity in nursing is important. I won't harp too long on this because I think Dean Beard did a wonderful job, but the problem is quite cyclic. Maybe you're seeing a deficiency of nursing faculty, a deficiency in the racial diversity of nurses. Maybe we're seeing decreased percentages in diverse recruitment. This ties into our biases. This ties into the compromised social determinants of health. And this goes into the disparities that we're seeing actualized. It doesn't start from one point, nor does it end at any other point, right? Looking at our diversity percentages in New York State, since we're talking Lincoln and it's in the Bronx, this is our current statistics. This is from our Future of Nursing report from New York State. The light blue is the general population and the darker blue is the nursing population. So just to give you an idea of where we stand today, our white peers, they make up 69% of the general population, 86% of nursing population in New York State. Our Black peers make up 17% of the general population of New York State, and we're at 5.5% of nursing. Our Hispanic peers make up 19.5% of the general population and 3.5% of nursing. And our Asian peers make up 9.3% of the general population of New York State and 3.5% of nursing. So considering these gaps, we were mentioning this earlier, how does that tie into the disparities, right? This evening, I will be sharing with you African-American health disparities because it ties into the history of Lincoln. But know that I am not diminishing or unaware of the other health disparities, other racial health disparities. But I focus on African health disparities because of this statement that has rang true for centuries. African Americans are more likely to die at early ages from all causes. This is from the CDC. And arguably, I will say there's not one point in time where this statement was not true. I always have to say it twice. African Americans are more likely to die at early ages from all causes. Now, I remember being in nursing school, being like, all of them? Really? Not one cause we can think of? So there's a reason for that, right? And when you're talking history, we want to consider, well, when we have these discussions, is it a repetition or is this something new? And often it's just repetition. We're just talking the same thing over and over again. So considering are these statements of the past or present, and you kind of got an inkling for this, Blacks accounted for 2% of the nursing population in the US in 1940. By 1920, the general population of nursing was 9%. But what I want to bring to your attention is that the percentages, although we keep saying we need to diversify nursing, the percentages of Black within the nursing profession increased 1% per decade. So if you look at this chart from 1940 to 1950, it went from 2 to 3%, 1950 to 1960, 3 to 4%. And so forth. So 1% per decade. So we're making changes, but I saw this comment in the chat earlier, it's incremental. And what does that mean in terms of livelihood and social determinants of health and health equity when you're only changing 1% per decade? Now, I'll ruffle a few feathers saying that when we had the initiative to increase men in nursing, it grew faster than 1% per decade. Looking at these statements again, the Institute of Medicine urging the profession, please increase the diversity of your nursing personnel to match the population. And there's also a statement saying the most serious deficiencies are reflected in the growing disparity between health status of your minority and majority populations. Well, one was from 2010, and another statement is from 1994. So I'm just showing you we've been saying the same thing for quite a while. And in some aspects, we're saying the same thing, but we're not learning from it. So looking at maternal death rates, we understand that currently in 2021, 2023, the statistic was that Black women are 3 to 4 times more likely to die after childbirth. And that statistic has actually increased, right? Some are saying 4 to 5 times. But I want you to look here to the left. It was not always 3 to 4 times. It was not always 4 to 5 times. It was less in 1940. It was 2.4 times greater. And then we see this percentage increasing and widening. So as a nation with growing knowledge, the smartest scientists, growing technology, and an awareness of health inequities, why is it that as time passes, this health disparity is widening? So in some cases, we're not only saying the same thing over and over again, but we're not listening to what we're saying, or at least we're not being actionable for change. So you might ask yourself, why is this happening? And some of us might be thinking, oh, well, it's biases. And I came across this poem that was published in the American Journal of Nursing that really tied in biases beautifully. And it's entitled Patient's Questions. I lie here at your mercy, nurse, while you perform your life-preserving functions, that I may possibly live a better life, or at least survive as medicine will provide. Will you give me the same care as another if the color of my skin is different? If I ask questions of what you do? If I scream when in pain instead of keeping silent? If my lifestyle is unlike yours? I ask you these questions, nurse, because I want to live and be accepted as a human being, maybe different from you, but not to be insulted for those differences. Over coffee and cigarettes on your break one day. And I think many of us can resonate with this Patient's Questions poem. of the biases that we're seeing in healthcare and how it just continues. So why do you think they're persisting? I'm putting these thought bubbles out. We really want to stretch our minds this evening. Why do you think these problems persist, and have we made any true progress? So while you're thinking, we're going to talk history. And the beautiful thing about history, my husband keep telling me, remove this onion. But there's a message for it of peeling back the layers. But he said I couldn't find a more attractive onion. But the beautiful thing about history is a lucrative mode of investigation. There's always questions, right? I want to keep peeling back those layers to get to the core of, well, where did this start? And often our history of nursing starts with Florence Nightingale, but I want us to go a little bit further back, understanding that the care of the ill was honestly rendered in homes, not in the hospital setting. People went to the hospital to quote unquote expire, right? I'm not a fan of that word. We're not gallons of milk, but you went there to pass away. So the care of the ill was done in the homes. But of course, Florence Nightingale, known as the originator of modern nursing, she brought about the notes on nursing, what it is and what it is not. I urge you to get these historical pieces of work. It's truly fascinating to flip through those pages and see the origins of our profession. And this manuscript influenced nursing schools. So Nightingale's standards really matched what we read earlier, right? She believed in female-led leadership. You had to be of a certain esteem, a woman of higher grade. There was an age limit. One had to be healthy and fit. One had to be unmarried without children, of course, because marriage was deemed a distraction to the art of nursing. And while there wasn't a clear delineation, one had to be white. So keep it, we're still in the midst of history, understanding that the first nursing schools established in the US was in 1873. And if you can stretch your mind just to think of any of the names of the nursing schools, we have Bellevue School of Nursing, Connecticut Training, and Mass Gen in 1873. So understanding why nursing schools were developed, I'm getting to Lincoln School of Nursing. So these are very brief glimpses throughout history. But between the Reconstruction era and the Progressive era, there was the Great Migration of African Americans and Blacks from the South to the North. They were seeking better wages, better, safer environments, right? But they were segregated in slums, unsanitary areas, poor educational opportunities, and high crime rates. Deplorable conditions equals deplorable outcomes. So TB was running rampant. You had infant mortality, pneumonia. In New York, this is an interesting thing to pay attention to. The death rates outnumbered the birth rates of Blacks every year from 1895 to 1904. So it was determined that the death rates in 1870, 1880, and 1890, the censuses were so staggering that New York Life's equitable actuaries, that's like life insurance, they confidently predicted the Black extinction by the year 2000. That's how bad it was. So I want you to take a minute and pause. Knowing this information, what do you think was the most profitable profession among the Black community at this time? If I'm saying so many people were dying, they predicted the Black extinction by the year 2000. And I'm opening my chat just to see if what was the most profitable profession in the Black community? There we go. Thank you, Asha. The Undertaker.
Takers.
The Undertakers, right? Because you had to have Black people to bury Blacks, right? So just getting a glimpse in time. So this started a Black hospital movement developed by Black physicians throughout the US. They said, listen, this is wrong. We need to fix this. Let's open up our own institutions. Let's train our own Black physicians. Let's train our Black nurses. But of course, it always comes down to the dollar sign. So although they were able to open these Black hospitals, they closed. Many of them closed due to lack of funding and financing. So we had to lean on white philanthropy, and we're looking at notable philanthropists, John D. Rockefeller, Carnegie, Rosenwald, and they funded 12 major Black hospitals, including Lincoln, that we'll discuss. But I want to take note that while white philanthropy had its good altruistic factors, this is one statement that stood out to me in my research. The General Education Board's interest is neither sentimental nor merely humanitarian. It is practical. The Negro race is numerous and widely scattered. It is with us to stay. Aside from any concern which on humanitarian grounds might be felt for the Negro for his sake, it is clear that the welfare of the South, not to say the whole country, its prosperity, its sanitation, and its morale, is affected by the condition of the Negro race. So in other words, we need them to be healthy, right? And I know you're seeing the words Negro. Please note that the terminologies used are taking exactly from the time that these words were said. But they're saying we need the Black population to be healthy, because if they're not healthy, it's eventually going to affect us. Let's help them open these hospitals dedicated for them. So when it comes to the Bronx, New York, we had a few name changes, but it ultimately came down to Lincoln School for Nurses. It was once known as the Society for the Relief of the Worthy Aged Indigent Colored Persons, and it was opened by a group of philanthropic white women, one of them being John Jay's daughters. And these were the sole two purposes for admissions: to provide education and professional training in the nursing arts for Negro women, and to improve access to care for Black patients by having Negro nurses to care for them. What was the admission criteria? One had to be respectable, intelligent, interested, and colored. These are a few images of the early Lincoln School for Nurses students. This is a copy of the application, and I know it's a bit blurry, my apologies, but take note of some of the questions that were being asked, right? You did have to have a reference talking about your character, your height and weight, right? Are you married, and so forth. One thing that was included in Lincoln's that wasn't included in other nursing programs at that time, like Bellevue, was good oral health. And I paused because I was wondering, why was good oral health on the application? Could you think about why they would want to know that these women, Black women, had good oral health in order to be nurses? See, some of us have our thinking faces on. Risk for infection. One thing that I considered and argued, talking to patients. Well, one thing that I argued was that this was a remnant of racism, slavery mentality. When one was selling slaves, they will pull their lips down to examine the gums. For if one had good oral health, that means you were able to eat and sustain health. And if one was healthy, then you could do work. So I found it interesting that the Lincoln School for Nurses application was an exact replica of Bellevue's, except they required the nursing applicants to demonstrate good oral health. Wonderful. Thank you. Thank you for your attention and keeping with me. So you'll hear me, Black woman, that was part of the admission criteria for Lincoln. So why not Black males? So this is from D'Antonio and Whelan. Let's see. African Americans may well have stayed away from nursing at a time when their masculinity was under constant political and economic assault from either subtle or overt racist practices. They felt vulnerable to its gender images, and they may well have kept away because Black women's hands on white bodies may have raised some sexualized anxieties, but those of Black men on white bodies represented completely unthinkable sexual images. So when we look at these discrepancies in the nursing population, and we wonder, well, okay, we're seeing Blacks, but what's the discrepancy between genders? Know that there was a while before Black men were welcomed into the nursing profession, and there was an individual school established later for Black men to attend. So Lincoln School for Nurses was established in 1898. It was the first school of nursing within New York City. where Black women had the availability to learn nursing. The first graduating class was a class of 6, and they worked their butts off. They would work a full 12-hour shift. This is a whole nother conversation regarding students, but students really ran the hospitals. They were like free labor. So the students will work a full shift, they will get a bit of a break, and then they will go to classes. Very arduous. So 3 years after the opening of Lincoln, the Board of Managers decided to open the hospital to everyone. Remember, Lincoln Hospital was primarily opened to care for Black patients, the ailing, destitute Black population at that time that were dying out. 3 years after the success of that first program, they said, you know what, let's open this to everyone. So this change came about 62 years after the establishment of the hospital and only 3 years after the nursing training school. And I think that shows the improvement of the health status and the contribution of Black nurses at that time for the expansion and success of Lincoln Hospital. So for anyone who passes by in the Bronx, just tap yourself on the shoulder and be like, wow, nurses, we rock. Look at what we did. We expanded this hospital. All right, a few images of Lincoln. I'm being very cautious with my time. Some of the earlier ambulances, a few images of graduating classes. Right, remember it started in 1898. If you're looking at the images, you might see that as time goes on, maybe considering principles of colorism, right? The first graduating classes were a bit of lighter skin tone. The pupils of Lincoln School for Nurses, they came from everywhere all over the US. Remember, this opportunity was not widely available. They came from Haiti, Caribbean countries, Bermuda, African. This was their opportunity to join nursing. While it was hard, they graduated and worked in private duty, which was the main job at that time, but they had issues assimilating into their professional status between titles that were given, whether they called you nurse or miss. They weren't able to join nursing associations, so they would have to join the National Association of Colored Graduate Nurses that was established in 1908, and instead of the ANA, which did not permit admission of Black nurses at that time. So just keeping these things in mind when it comes to the professionalization. And what I noticed about the graduates of Lincoln, they were promoted with an asterisk. They can get so far in the hospital, but they weren't able to work as supervisors. They weren't able to work as faculty of the school. Here's a school that was established to educate Black women in nursing, and the graduates couldn't teach within it. But they can be like clinical instructors, but not faculty, and no leadership positions. So they resorted to moving to Southern schools to obtain their leadership experience. Research that I wanted to share was that of Ethel Johns. So the fun thing about history is when people will say, well, there wasn't racism in nursing, or those issues didn't really exist. And I'll tell them, move aside and let me print my receipts, because I got receipts when it comes to historical research. And one of them is the Ethel Johns report. Ethel Johns was a Canadian researcher hired by Rockefeller Foundation in 1925 to study these Black nursing schools. And this is some of her observations. This is what was said to her. Ms. Ford thinks that colored head nurses, who are almost without exception graduates of Lincoln, do their best to supervise their wards properly, but she is doubtful about their capacity to fill positions which entail very heavy responsibility. She is sure that discipline cannot be maintained unless there's firm and competent white direction. The white directors of social service and outpatient departments agreed with Ms. Ford, though they presented the case from a different angle. They told me that colored nurses are accepted quite naturally by the white patients because they know that these nurses are under white direction. Were they to be placed under colored supervision, they would not be accepted at all, and a valuable nursing experience would thus be lost to them. I inquired whether white patients would not accept the services of colored physicians, since they are willing to have colored nurses wait upon them. The reply was strongly in the negative. This apparently is the reason for exclusion of colored interns. So when you're looking at the makeup, of your nursing faculty, your clinical instructors, the makeup of nursing, remember to peel back the layers, right? When did this discrepancy start? What is the evidence of that? Okay, I see, I'm looking at my time. I'm just going to go through a few things. So I wanted to introduce you to two trailblazers. I won't go through their slides because it's quite lengthy, but Ada Tomes and Ivy Natan Tinkler. Ada Tomes was a graduate in 1905. She helped establish those nursing organizations like the National Association of Colored Graduate Nurses. She advocated for nurses to be included in the Army and the Nurse Corps. So she really wrote and advocated for the inclusion of nurses. And she was able to land the first supervisory position within the school. She was the assistant superintendent for 18 years, but they never gave her the official title of superintendent, which at that time is like a dean. Ivy Natan Tinkler became the first Black superintendent officially of Lincoln School for Nurses in 1954. Okay, she was a graduate of Lincoln, class of 1931. And her career really spanned what I demonstrated, having to leave to go to Southern states to gain that leadership experience before coming back. Okay. What I love about Ivy Natan Tinkler, she was able to diversify the school. At one time, there were 23 nursing faculty of color teaching. So I want you to think of any nursing school. Whoa, what nursing school can I walk in where I say, this is true diversity, 23 faculty of color. And she admitted the first white student to Lincoln School for Nurses. Okay, I'm skipping through because it's lengthy and I want to be keen on time. Okay, so what happened to this school? Lincoln School for Nurses opened in 1898. It closed in 1961. Why? Well, they said the purpose of the school is fulfilled. You have Black nurses or Black nursing students. You can go to any school that you like because now segregation is ruled illegal. Go where you like. Well, that wasn't the case, right? Even though segregation was ruled out and you were able to apply, doesn't mean that they were accepted. In total, there were a total of 1,864 graduates of Lincoln School for Nurses. So please, if you meet any nurses, even if they're from the Caribbean, Bermuda, Africa, all over the US, ask them, where did you go to nursing school? This is a reflection from a student in their last yearbook. In keeping with most educational processes here in America who have undergone dramatic change in response to modern social and technological demands, Lincoln has undergone a metamorphic change from a training school for the preparation of Negro nurses to care for Negro patients to an institution of higher education of Class A rating, recognized and approved by the National League for Nurses and the American Nurses Association, and is deeply respected throughout the world. So here we are, right? We've integrated, quote unquote. Now what? The problem still persists. Now what? We're still seeing these gaps in our diversity numbers. And this sentence is still true, right? So while there is progress, while we have our diversity and inclusivity officers and committees, and we're doing our education, we're trying to improve our diversity changes, I want us to consider where history lies in our responses. I was quite ashamed that it wasn't until my doctoral studies at Teachers College, Columbia University, that I uncovered Lincoln School for Nurses by peeling back the layers myself. This history was not provided to me. I do believe that if it is not written and acknowledged, it can easily be erased and forgotten. These women did wonderful things. I want you to consider your own history. What are you doing in nursing? What are you fighting for? What are you standing for? And while the fight might be tiring, and I know that many of us are tired, I want you to know that every little bit that you do on this journey of nursing counts. How are you shaping your history? And understand that your history is golden, that what you do matters, and that you are capable and appreciated and valued. Thank you so very much for your time and your attention.
Thank you so much, Dr. Ashley Graham-Perrell. What an amazing history. Not even realizing this right here in New York. And that hospital goes on to have an impact on the care of Black patients as the history continues. And you think about their resilience and so forth. Just amazing. Definitely gives us things, something to think about as far as perseverance. A lot of kudos in the chat. Wonderful presentation, important work. Thank you, thank you.
Thank
Are
you
there
all.
any questions for Dr. Graham-Perrell? We have time for one or two. We have a question from Dr. Celia McIntosh.
Hi, how are you? Thank you for that excellent presentation, but I just wanted to ask you a little bit about self-care in this process. Because like you said, the work is daunting and we have a lot of work to do.
Mhm.
But just even going through this and, I guess facing like the reality that a lot of this has been erased, you've never been taught this, and you want to do a deeper dive, like what kind of approach did you take for self-care as you're going through this work?
Thank you so much for that question, Celia. I think one thing that I recognized during my research and my continued research is that history is troubling to the soul, and that you really have to take moments to pause and reflect and really give yourself the grace to say, I am learning. Someone asked me for advice on how to do historical work, and she felt guilty for presenting this information. And I said, please don't take on that burden. You are presenting a moment in time and you are giving receipts, right? You do not have to try to justify why this happened. You are just sharing what happened and possibly why. But it did have its daunting moments. You do have to recognize that the history could be troubling and it does repeat itself, right? So sometimes I would read research and it'll say they wouldn't accept care from Blacks, but also the Black patients felt offended when a Black nurse would walk in, right? They'll feel like they're getting the mediocre care. So that was tough to read. Or if anyone was ever promoted to a leadership position, and pardon the explicit words, but this is what the research literally said, how Blacks worked their fellow peers, that a nigger must work a nigger. That was in the research. So seeing those things, I had to step away and say, oh boy, this is tough to read. But understanding that I'm reading through a moment in time, this is history. I'm seeing a few notes. Could I mention a little bit about Mary Elizabeth Carnegie? Thank you so much, Trudy, for mentioning Dr. Carnegie. Dr. Carnegie was a graduate of Lincoln as well. If I gave the extensive history, I would have included her. Dr. Carnegie wrote The Path We Tread, all right, Nurses in History. And I believe it ended at 1990, 1854 to 1990, a must read along with Black Woman in White by Darlene Clark Hines. Those are the two books if you want to understand Black nursing history. I encourage you to read those two pieces of work. I see one last comment. Have you considered adding Mary Seacole? Yes, I have. And generally I do try to work on paralleling. Whenever I talk about Florence Nightingale, I try to include Mary Seacole, a Jamaican British nurse who was denied time and time again from working alongside Florence Nightingale. There are historical works of Florence admitting that Mary Seacole was a great nurse, was a sound nurse, so she gave her props, but she just wouldn't allow her to work. So what Mary did, Mary said, well, fine, I'm just going to set up shop next to you, right? Mary was the first one to write historical pieces in nursing, so she does have works as well. She was able to open a bit of a hotel and hospital for the soldiers. Really tremendous, and she's now getting her flowers. There is a statue of her, I believe. Is it in Jamaica or in the UK? I'm not too sure, but I know she's getting her flowers. Is the Lincoln School still standing? No, it is not. It closed in 1961, but there are
have one-
archives in the Lincoln
Oh, go
Hospital
ahead.
when you walk in the building. Is the building itself standing? No, it is not.
Marilyn, you have your hand up. One last quick question.
Okay, thank you. Actually, I was the one that wrote about Mary Seacole, but there is a statue now in England for her. I don't believe there is one in Jamaica at this time. And she used all of her own resources to pay for herself and I think 15 or 20 nurses to go with her in the Crimean. So thank you for adding her. I hope everybody would add her into our history.
Thank you for keeping her name alive and for the gentle reminder. I appreciate it.
Dr. Graham-Perrell, thank you very, very much. This is so informative, and we really need a whole session on the Black nurse history. There's a lot to be said, and I'm sure some of the lessons learned back then could maybe be used nowadays on how we can navigate and impact healthcare disparities. Again, thank you very much. Truly appreciate you sharing your knowledge with us. And we're going to move forward with the program. Next on our agenda is Dr. Rebecca O'Connor. When words are censored and the world is divided, nurses conquering the innateness of bias to advance health equity. Dr. Rebecca O'Connor is an associate professor in the University of Washington School of Nursing and the inaugural Betty Irene Moore Nurse Leaders and Innovators Fellow. Her research, teaching, and service reflect her commitment to addressing bias in nursing and beyond. She collaboratively developed and leads the Implicit Bias Clinical Education Program, iBias, implicit bias training for health science students, faculty, and research teams, and a 3-day anti-racism and DEI teaching institute for the School of Nursing faculty. Dr. O'Connor received the School of Nursing Student-Nominated Excellence in Promoting Diversity through Teaching in 2016, 2018, 2019, and 2021, and Excellence in Graduate Teaching in 2022. Please welcome Dr. Rebecca O'Connor. Thank you so much.
Thank you, Dr. Stamps. It's an honor to be here with my colleagues, Dr. Graham-Perrell and Dr. Beard. And note to self, don't ever agree to follow them because this is a losing proposition. So I wanted to start off by respectfully acknowledging the traditional lands that I am on. That's the Coast Salish peoples and lands that touch all of the shared waters of tribes and bands within the Suquamish, Duwamish, Muckleshoot, and Tulalip nations here where I am in the Seattle area. And also want to recognize that land acknowledgements have become more widely used, but they are far from sufficient to address the longstanding harm and indigenous dispossession that has occurred based on our history of taking lands. And you can find out whose traditional lands that you are on at nativeland.ca. I also start off conversations that I have with being really explicit about my positionality, which I think is really important in talking about myself as a white, gay, cisgender, overeducated, and upper middle class woman. And my focus is on bias in providers and how that's contributing to inequities. And so I'm going to be talking about that bias being based on racism, as we've been discussing throughout the afternoon and evening. I'm going to get things wrong from time to time. As much as I try to understand and learn the experiences of others, I can only understand truly my own. And so I definitely invite the opportunity to correct me when I do, because that's a learning experience for all of us. And I also want to pause, as it happens when we engage in this work. I was teaching earlier today and had an amazing Black pediatrician talking to the class. And afterwards, a student shared very vulnerably their rage and pain from the conversation because their brother, a Black man who was 37, died a couple of months ago from a stroke, and shared the repeated instances of not being believed, of being dismissed, of care being prolonged. And she's a stroke nurse, ironically. And just wanting to pause on this second point and honor and recognize that these aren't academic conversations for people who are experiencing racism and bias. These are fighting for your lives every day, your lives, your family's lives, your friends' lives. And just want to be really explicit about that. And as I often say to the students and to all of you, please prioritize your own care as we move forward in the conversation. Skip the objectives. So I've apologized. I missed the first part of Dr. Beard's conversation. I'm not sure if she addressed this or not, but we've known through definitive research since 2002 that biases among healthcare providers is contributing to preventable health disparities. And not surprisingly, this finding is very alarming to many healthcare providers because we don't go into healthcare to cause harm, right? We're trying to do our best in really difficult circumstances. And so providers really struggling with the fact that we actually do indeed inadvertently cause harm to our patients. And so a lot of times we're talking about implicit biases as these thought processes, they're automatic, we are unaware of them. But the important piece is that the automatic associations that we do make are informed by the society that we're in. They're not by accident. So we're going to take a quick look at a video that demonstrates this quite well.
Implicit bias.
Implicit bias.
Implicit bias.
2016 was the year that implicit bias went somewhat mainstream.
Yeah, so when Hillary Clinton mentioned implicit bias in the debates, our phones started blowing up, all our friends started emailing us about it.
But what is implicit bias? Implicit biases are basically thought
Apologies, I don't know why that stopped.
processes that happen without you even knowing it. Little mental shortcuts that hold judgments you might not agree with. And sometimes those shortcuts are based on race. First, some clarity. Saying someone has an implicit bias is different from calling someone a racist.
The word racist is a highly loaded term, right, here in American society. A lot of times when people are using it, they're thinking of the kind of old-fashioned Ku Klux Klan style racist.
But implicit bias isn't anywhere near that explicit.
Implicit bias is something that comes out of ordinary mental functioning, out of how the mind normally works.
We've all grown up in a culture with media images, news images, conversations we heard at home, our education. Think of that as a fog we've been breathing our whole life. We never even realized it, what we were taking in.
And that fog causes associations that lead to biases.
I somehow know that if you say peanut butter, I'm going to say jelly. That's an association that's been ingrained in me because throughout my life, peanut butter and jelly are together. And in many forms of media, there's an overrepresentation of Black men and violent crime being paired together.
And because of that, I actually deep down inside have been taught that Black men are violent and aggressive and not to be trusted, that they're criminals, that they're thugs.
With all those associations, I'm not trying to let us off the hook, but in some ways, none of us stood a chance.
Starting today,
It is true that implicit biases are unconscious associations. They're pervasive. We all have them. And even those with strong egalitarian beliefs and those that experience bias and discrimination themselves. They, of course, occur most often when we're rushed and have high cognitive load or are tired, which is healthcare every single day. And they don't necessarily align with our stated beliefs. And this is one of the things that we see happening all around the country when we're trying to have these conversations, is there's this cognitive dissonance when it's pointed out that I can at the same time be a good human, be a good person with all the great intentions, and inadvertently perpetuate racism. And generally it favors our in-group, and we are negative about our out-groups. But research shows that we can also preference out-groups, particularly if those out-groups hold power. So for instance, women preferencing men over other women. And importantly, the effects are malleable, and that's what we're going to talk about in just a few minutes. So talking a little bit about what's going on in our brains. Our brains can process up to 11 million bits of information every second, but we can only cognitively process about 40 to 50 bits of information. So we need shortcuts. And our brains are really efficient in doing this. We're able to walk down the street and be in really complex settings and still function and not be completely overwhelmed. But the problem is we don't always get it right. Frequently we get it wrong, and it's this idea that we have mind bugs and our eyes are playing tricks on us.
Want to catch your brain making a mistake in real time? Take a look at this checkerboard, created by vision scientist Edward Adelson. The squares labeled A and B are exactly the same shade of gray. Don't believe me? I don't blame you, I see them as different too. But here's the proof. Simply connect the two with this gray bar, and voila. Suddenly it's obvious. A and B are identical. Here's the strange thing. Remove the bar, and the illusion comes back immediately, just as strong as it was before. We can do this again for the skeptics. Different shades of gray, same shades of gray. Different, same. Our eyes can see that A and B are identical, but our brains fall for it every time, no matter how often you debunk the illusion. Why? Professor Adelson points to two specific details. First, contrast. A looks darker because it's surrounded by lighter colored squares. The opposite is true for B. Second, take a look at the soft edges of this darker section. Our brains see this and think, ah, it's a shadow. We know that objects in shadows look darker than they actually are. So our brains compensate for that by making us actually see B as lighter. Something else to consider. We all know what a checkerboard pattern looks like. So we come into this illusion already expecting A and B to be different, and that could influence what we see. What about expectations we have about people? Which face is darker, the one on the left or the one on the right? Psychologists Daniel Levin and Mahzarin Banaji found that most people, including Mahzarin herself, see the black face as darker than the white face, even though the two faces are the exact same shade of gray. Again, debunking the illusion is simple. Here's an idea from Dan.
Just cover up the lower parts of their faces. You'll be left with two foreheads and they'll look exactly the same.
The features of the face matter. But in a second study, the researchers showed that you could create this illusion using the same face. People saw a racially ambiguous face labeled black as darker than the same face labeled white. Did you?
So if you want to just throw a couple of examples of automatic associations or bias that you have seen in healthcare, we all, I'm sure, have many, many examples. Because I'm Hispanic, I speak Spanish. Male nurses are queer. Black nurses are the housekeepers. Yeah, there are an unending number of examples. So we have lots of evidence that shows that implicit biases among healthcare providers causes increased morbidity, mortality, and differences in patient-provider interactions, treatment decisions, and healthcare outcomes for numerous groups, right? We've known this for decades. And it's important to point out that, as you can see on the right-hand side, of the screen that there are numerous marginalized and racialized identities that are the target of bias and discrimination in healthcare. We've got lots of evidence of racial bias and other bias in algorithms, and that's only increasing with the use of AI. In this case, it came out a couple of years ago. This was a huge Medicare algorithm that assigned additional care upon discharge to patients to try to prevent readmission. And the algorithms assigned much lower levels of care to Black patients based on, compared to white patients based on the level of healthcare usage before they went in the hospital. So the idea was, well, the sicker you are, the more you use the healthcare system. What's the problem with that assumption? Well, there's several problems. What might be the problem of the assumption that all patients of all racial backgrounds would seek care in the healthcare system if they need it? Some might wait too long to seek care if they don't have insurance. That's a number one big one. Why might they wait too long to seek care? Fear of maltreatment and seeking care. Yeah, exactly. For all of the reasons, especially that Dr. Graham Perel shared with you, there's very good reason why numerous communities avoid the healthcare system, because when they interact with it, they're harmed. And this is another example, again, and I will just briefly, did Dr. Beard talk at all about Serena Williams?
No.
Okay, thank you. I'm just going to say very briefly, because there's her situation, so I want to get to a thought experiment about this. So Serena Williams had a history of a previous pulmonary embolism from a long international flight about a decade ago. This is her beautiful baby, Olympia, who's now 5. And when she gave birth to Olympia, it was via cesarean section. So that's another surgical procedure. And the next day she shared with her nurse that she was short of breath and thought she might be having another PE, and asked for IV heparin and a CAT scan. She was not asking for pain medication. She was very specific, and she knew her body, and she shared with her nurse this. And her nurse's initial response back was, "You must be confused because of your pain medication." This is Serena Williams, one of the wealthiest and most recognized and respected humans on the planet. So part of this is thinking about how many times every day does this happen, that we don't believe people when they tell us exactly what's going on. That's that automatic association. For whatever reason, I don't think the nurse had any intention behind it, but for whatever reason, she did not believe Serena Williams, who then told another provider, got the correct diagnosis, did have a pulmonary embolism, and obviously got successful treatment. Where I wanted to pause and think about this, and this is where I share with people, especially that don't think about implicit bias in healthcare. What would have happened if Serena Williams would have died? She would, her death certificate would have said pulmonary embolism secondary to complications related to childbirth. Yet another beautiful Black woman who dies and becomes a maternal mortality statistic. The problem is that's not the cause of death. That would not have been the cause of death. That would have been the mechanism of death. The cause of death is because we did not believe her, because of the automatic associations and assumptions that are happening all of the time. This is why it's such an urgent issue that we address implicit bias. So it's an urgent patient safety issue. And to effectively address it, we've talked about this throughout the evening. We know the statistics, we know the data. It's been evident for decades, and yet we're still having this conversation tonight. We need a culture shift where we normalize that every person, despite our best intentions, despite whether we experience bias and discrimination ourselves, has bias. And like medication errors, it's not a matter of if, but when it impacts our nursing care. And it's not enough to have abstract conversations on a virtual conference or in a classroom about bias, although that's important. We have to change behavior in care settings. So we're also operating in a time where we have about 20 states that have laws on their books or are pending laws saying we can't talk about racism and we can't talk about bias. We don't want to make people feel bad. But the truth is people are dying every day, all the time, because we're not having these discussions. And to reiterate, discrimination takes bias plus action. But if we don't think that we're part of the problem, that we don't think that we have bias, then we think we're just making decisions based on the facts of the situation. So getting really quickly to what we're going to do about it. In general, equity and justice work is never done. And it requires constant and genuine self-reflection and humility. There is no perfect conversation about racism. There is no perfect conversation about bias. We have yet to achieve true health equity anywhere in any space, or equity in general. And so it really behooves us to be willing and honest to say how we're participating in part of the problem and what are we going to do to fix it. And that when we make mistakes, they're going to happen. So how do we respectfully and authentically apologize and prevent that from happening again? It also requires continual learning about identities we don't share, and not asking people who are marginalized and racialized to teach us. That's on us. And one of my favorite ways to actually learn and listen from people without asking and overburdening them is podcasts. Folks have already shared and been willing to share their stories. And so that is a way in which we can really, really hear the experiences of others. And it's best done together and seeking out others who are doing the work, because not only do we need to hold each other up in this is very, very difficult, challenging work. But collaboration also furthers accountability. So we're not out on some island thinking that we're actually doing good when we're causing harm. So first, we need to recognize and disrupt bias and inequitable policies and practices and norms. They're everywhere. It's like when you get a car that's new to you and suddenly you notice that car is on the road all over the place. As soon as you start looking for biased and inequitable practices, it's in everything. So in our hiring and promotion and retention practices, I'm sure that a lot of you have been in a hiring conversation at some point in your life, or you will, where someone will say, yeah, but I don't know that there's a good fit for our group. And what we're really saying is, well, they're not like us. And if white folks are disproportionately holding positions of power and are disrepresented, as Dr. Graham Perel shared with us in nursing, more often than not, it's going to be white nurses saying, the BIPOC nurses, just not really a good fit. What about norms in meetings and other spaces and whose voice is considered and centered? Prioritization for who gets time off on the units. Disproportionate calls for safety calls on patients and families of color. Visitor policies, especially in COVID, post-COVID, this has gotten really, really nasty because, oh, you know somebody on the unit? Well, you can come in, right? And then suddenly we're making subjective decisions about who has access to their sick and oftentimes dying loved ones. EBP and clinical guideline usage, which we're going to touch on, and then the use of interpreter and translation services one of the most commonly observed situations that biased and inequitable situations in healthcare is the lack of nurses using interpreter services and just talking louder in English. And lots of others. So I want to get us to this point so we can talk just for a few minutes about what we're going to do about it. One of the leading researchers on bias talks about it as being, it's like breaking a habit. You got to try to do it over and over and over again, and it needs constant attention. So we need the intention to acknowledge that we have implicit biases. Again, going back to the story I shared that my student shared earlier today. This isn't, we all abstractly and academically say, yeah, we have bias, but that's everybody else's problem. It's not my, I got mine in check. Everything's under control. We have to move away from that and really try normalize the fact that this is ongoing and we're always part of the problem, each one of us, all the time. And attention, are we going to pay attention to the triggers that get us to respond in stereotypical ways? And then also time. We have to make the time and the effort. For timing, I'm going to skip that. So long story short, along with Dr. Beard's guidance and some other really phenomenal people, we've developed a clinical, implicit bias clinical education program where we are having students throughout their undergraduate courses demonstrate bias interrupting skills every single day they provide care. So that in our program, by the time that they graduate, they will have demonstrated these skills more than 50 times. So that just like the 5 rights, this is something that we're thinking about and considering all the time. It's a normalized part of providing patient care. They come out of, their evidence-based come out of social psychology research. Becoming aware of what your own biases are, if you haven't already, and even if you have, continue taking implicit association tests. Understanding and respecting the magnitude of implicit bias on healthcare, which you've heard throughout this evening from Drs. Beard and Graham-Perrell. Slow down decision-making. Practice emotional regulation, entering all encounters feeling positive. Don't let the argument with your partner carry over into your patient care the following day or hour. Practice individuation. So treating all patients, research participants, families, whatever, as unique individuals with unique needs and asking them what they need rather than making assumptions or what they don't want. Practice perspective taking. Consider alternative experiences and realities. Building equitable partnerships. And that means collaborating with patients and families to accomplish goals, their goals. Perform teach back in every situation. Use respectful rather than paternalistic language when doing teach back as well. And using guidelines consistently in every situation when they're available. Persist in finding possible alternative reasons for decisions. And that's in ourselves and in others. Question stereotypes in selves and others, and identify when implicit bias might be impacting the statements and actions of ourselves and others. So I just want to point out one thing really quickly. These are not rocket science. And in fact, the ones in gold are the core to patient-centered care and family-centered care that we're supposed to be doing every time we provide care, and yet we don't consistently. And who don't we consistently do it with? Patients and families and communities that are marginalized and racialized and minoritized. Just like surgical checklists, it's not rocket science. Counting 17 sponges going in and 17 sponges going out is not rocket science. It's intentional attention to places in care where we know there's a problem. We know that people are dying. We know that bias is playing a role in it. And we know that it hasn't gotten any better. So how are we going to make these culture shifts? And asking you to think about, maybe for 20 seconds, since we're behind, what 2 to 3 steps can you commit to doing over the next month in your work? Yeah.
During
It's
times
true.
of haste. Oh, yeah.
I'm
Words
happy
are
to share
censored
it.
and the world is divided. Oh,
I'm
that's
happy to
insanity.
share this, Dr. Stamps, with you, this slide to share with participants if folks are interested. And I would just say thank you all for being here, for thinking about these things. Dr. Stamps and Graham Perrell and Beard, thank you for your work and your friendship. I admire you all so. And thank you for having me.
Thank you so much, Dr. O'Connor. Definitely, we have to be more conscious and intentional in our behaviors and our actions. And I love the opportunity for us to be thinking about what are we going to do differently, slowing down our decision making, practice individuation, perspective taking. I love what you said about entering every situation from a positive lens. So many times we're already thinking it's going to be bad and we're all stressed out before we even get in there. But truly taking that lens of positivity would be great.
Yeah.
Something to really work on. Thank you again. Does anyone have any questions for Dr. O'Connor? Yes, we will share the last slide. We'll send that out to everyone. Thank you. Very thoughtful presentation. Love the thought of wrapping awareness of bias into clinical experiences. Eye-opening, thank you. Powerful, great presentation. Love the videos. Videos are amazing. Really puts things into perspective. We have a question from Dr. Celia McIntosh.
You know how I do. Okay, let me see if I can straighten this one up. Okay, so I definitely understand the bullet points are very helpful. But some of the things that I get stuck on is when we can't really teach people even human decency. Like, how do we even transition into these points? It's like, what are, because it's kind of like you have to kind of develop a little bit of open-mindedness with people first. So you have to get to that level with them, kind of like some people like it's not really a maybe stage setting or something, or I can't think of the word right now, but it's just like some people can't even do human decency or learn. You can't teach them that. How are we going to get them here? So it's just like with your bullet points, with your kind of framework, what would you suggest to kind of like maneuver that conversation?
Yeah, that's a great question that we could spend hours, days on. Briefly, I will say, there's this podcast, and I can get the reference later. It was talking about whether DEI trainings are work or not, which is that's a very long story. And as you can see by this, that if we're going to do behavior change, it's much more than a training or a conversation, right? It's got to be over and over and over and over again. But basically, they said there's 3 kinds of people. There's dolphins who want to do good. There's ostriches who don't care and put their heads in the sand. And then there's sharks that are actually invested in keeping the system the way that it is and promotes that because they benefit, right? And the point was that we have a misconception that there's a lot more dolphins that there really are. They said, really, I'm getting the numbers wrong. He's like, we're like 5 or 10% dolphins. We're like 50% ostriches. The problem is everybody thinks there's hardly any sharks. There's a lot of sharks. There's a lot more sharks. So Long and short of it is, it can't be about changing hearts and minds. It has to be about changing behaviors. And so how do we put systems into place that force people to do it? Right? Whether it's something in the EHR, whether it's a job work evaluation criteria. So what I'm talking about is at the individual level. So I'm going for the 80%, right? The 10% is not going to listen to us anyway. The other 10% or however many are already doing it. We got to try to get some of that 80% to change the behaviors, and they will be motivated to do it, and we'll do it. And we have to change systems. And so I would say to you, you're talking on a systems level solution for those folks, because I don't think anything that we're going to do on the individual level is really going to move the needle, unfortunately.
Thank you. Thank you so much. Amazing. I always love to hear about your work and really incorporating that into how we are teaching the future nurses. Chineza, last question.
Thank you, Dr. Stamps. I'm a student nurse here at Columbia, and I've been privileged to go to some hospitals for my clinical rotation. One of the things I've noticed of differentiated nurses is clinical nurse managers. And I've seen that when a nurse manager has a big heart, most of the nurses under him or her, they also have big hearts. And yes, behaviors cannot be changed in adults, but there's something that nurses can do, and that is in leadership. Maybe we could do something in leadership. Maybe we could put people that really do care in leadership, and they can implement strategies, standard operating procedures that can bring younger nurses or new nurses into a place of accountability in discharging their duties and responsibilities. It's really disheartening for me as a new student nurse when I go to the hospital, very excited to meet people, very excited to learn, and then I begin to see racism. I saw it in OB rotation, and I don't want to be an OB nurse, and it's very disheartening. Thank you so much for this opportunity.
Thank you so much, and sorry you did not have a good experience. And that is a wonderful segue into our student nurse panel. We have 4 amazing students from across the country, and we are going to talk about, by now I should know how to share my screen, but I'm not doing very well tonight. Dr. O'Connor, again, thank you very much. Very insightful work, a lot of work to be done. So our student nurse panel, amazing 4 students that are going to speak with us from across the country. The topic of our panel tonight is, what didn't you learn in nursing school? We have students with us, Brianna Finley, who is a DNP student at the University of Washington School of Nursing. We have LaQuisha John, who is an accelerated bachelor's weekend nursing student at Mercy University. We have Christina Mavis, who is a BSN student nurse at Georgetown University, and Aisha Miners, who was actually with us last year, and she is back as a doctoral candidate at the Doctorate of Nursing Education Teachers College at Columbia University. Please welcome our panel this evening. Wonderful, wonderful. Thank you all for being with us this evening. I'd like to begin with introducing yourselves and then just sharing a little bit about why you chose to be a nurse. And then we'll go around again and talk a little bit about some of the challenges that you've had and how you've managed them. So let's start with Brianna.
Hi, everyone. Thank you for having me. I'm Brianna. I'm a doctoral student at the University of Washington, like Dr. Stamps said. I chose nursing because, like Maddie said in the chat at the beginning of the presentation, nurses have the hard conversations. We're the ones who spend the most time with the patients. We get to know them. We're the ones who, in the ICU, bring voices to patients who enter in altered mental states, wanting them to be given the best medical care. We're the nurse supervisors overseeing 6 units, wanting to give our staff the best care and support. we're the ones who sit and listen to caregivers who just lost their loved ones and really empathize with them. We get to know people on a vulnerable level, and we get to be the human factor in healthcare is what I like to call it. We get to be humane, and spend the time that providers might not have or might not realize they need.
Thank you. Thank you so much. LaQuasia.
Hi, good evening, everyone. My name is LaQuasia John. I am in the second degree accelerated weekend nursing program at Mercy University. I will be graduating in May of 2024, which is this year. Why did I want to become a nurse? Nursing is very dear to me because it started at the tender age of 3 years old. I was diagnosed with retinoblastoma, and having faced such a traumatic experience, I found that the nurses were my go-to. They were loving, they were nurturing, they showed me the affection that I needed at such a young age. You know, at 3 years old, I didn't know much, but over the years of, seeking treatment and having them side by side with me, I knew that that is who I wanted to become. I wanted to give back to the same people that gave back to me. They gave me a second chance at life. So I wanted to do the same.
Thank you. Thank you so much. Christine.
Hi, everyone. My name is Christine. I'm a senior at Georgetown University, which is located in Washington, D.C., in the undergraduate program. And the reason why I chose nursing, it first started when I volunteered at the hospital in high school, and I got to see what nurses were doing and how much of an impact they had on a patient's journey. And it really resonated with me how, during your someone's stay at a hospital, it's usually a vulnerable moment of their life, where they can have like an abundance of negative emotions or overwhelming responses to it. And so I feel like nurses, like you remember a good nurse, and they help patients through navigating their journey at the hospital, which I admired. And I also like the direct patient care aspect of it too. So, yeah.
Thank you. And Aisha.
Hi, good evening, everyone. My name is Aisha Souffrant. I am a doctoral candidate at Teachers College, Columbia University. I'm also a registered nurse at Hassenfeld Children's Hospital in pediatric oncology, as well as pediatric recovery. Why I chose to become a nurse back in 1997, my grandfather was diagnosed with myeloma of the bone, and I saw that he had received hospice care at home. And the nurses that came in were so profound, not only that they helped provide comfort during his last time before dying, they also provided care for the family. And that just stuck to me, how the nurse took care of the patient, but took care of the family and all the dimensions of my grandfather. And so I was like, that's what's missing. That's what I like. So that's why I chose nursing.
Wonderful. Thank you so much. And we have Chinasia Laquando from Columbia University.
Hello.
I'm so sorry I left you off the introductions, but thank you so much for being here with us this evening. Tell us a little bit about you.
Thank you.
Awesome.
Yes.
So my background is in research.
153rd Street.
Can you hear me?
Yes.
Oh, or am I able to go to the one Bronxville?
So my background is in research. I started out in clinical research, and I saw a lot of things that I didn't like there, especially with recruitment and retention of participants deemed as subjects. And I felt that being a clinician will help me reach out to the minority. And my question was always, what was the problem? First, I thought it was racism. But as I came to nursing school, I saw it's a combination of a lot of things. So I came to nursing because I wanted to go back and advocate for people like me.
Thank you. Thank you. So our panel tonight is, what did you not learn in nursing school, or what did nursing school not teach you? And when we had our brief planning session, you all shared some amazing experiences. And so let's talk a little bit about, what did nursing school not teach you? Who'd like to begin?
I can start. I think when we did our dry panel, I really discussed the mental health burden of becoming a nurse, not only being a nurse, but also in nursing school. And just kind of want to speak to the statistics too, especially since COVID. Rates for PTSD, anxiety, depression, and emotional exhaustion have shot up to like between 30 to 60% between nurses. And over 40% of nursing students express having depression, anxiety. So I think going through nursing school, they didn't really teach us how do we take care of ourselves. It was always about the next exam and the next check off, and you have to put your patients first. And while that's really important, we have to take care of ourselves to be able to take care of our patients. But something I didn't discuss with Dr. Stamps that I kind of want to talk about that ties into this whole discussion we've had tonight. Nursing school also didn't really touch on the like differences between learning about social determinants of health and racism being the cause. Really, I think we used social determinants of health and other words to kind of mask and sugarcoat a lot of what we learned in nursing school. For example, we learned about primary versus secondary and tertiary care, but we didn't learn in the context of racism, health inequities, disparities, and unmet social needs. So it's hard to have those conversations while you're also trying to enter the workforce. It's also hard to have those conversations while you're learning very task-oriented stuff, like putting in a catheter, and the stuff that goes along with that. But learning stuff like the Dr. Kamara Jones cliff theory and focusing on the ambulance at the end of the cliff. And if you don't know what I'm talking about, I can put it in the chat. I feel like nursing school is very focused on the ambulance at the end of the cliff and like catching people who fall off the cliff. Whereas we need to have more of an outlook of pushing people back from the cliff, providing that primary care and assessing social determinants of health instead of having such a focus on, all right, this is what you do once people are in the hospital, which I felt was how my nursing school experience was driven.
Wonderful. Thank you for sharing that and elaborating even more so. And I love the example of the ambulance hanging off the cliff. That's so true. So true.
So for me, nursing school may not have taught me personally how to deal with bias from patients towards myself and racism. I have been a victim of racism in the workplace. So, I know what it feels like to be targeted. I know what it feels like to be separated. I know what it feels like, to be retaliated on. And, even though I reached out for help, I feel like, everything was like covered up. There was really no support in, in the fact that, I was experiencing this, and I felt like too, it's not just emotional, it's psychological. It takes a toll on you. You as an individual, you want to be treated equally. You want to, have the same rights as others, and you don't want to be signaled out. So, it's hard for us to have these conversations, but these conversations need to be had. And I, maybe even added into the curriculum, talked about in the classroom, even maybe, acted out in the classroom, have the students, somebody be the doctor, somebody be the manager, somebody be the patient. There are patients targeting the nurses and, healthcare workers. There is management attacking their employees, and I don't feel fully equipped, So, I'm about to graduate as a, new grad nurse, and I want to be able and capable of, going into wherever I work, any facility, and knowing that, my team stands behind me, regardless of my color, my race, whatever, my gender. I want to be supported. So I feel like nursing school may not have taught me exactly how to approach that. And maybe that should be implemented in the classroom.
So sorry again that you experienced that in your workplace.
To add on, similarly, like I also feel like nursing school didn't really teach me how to navigate through workplace culture. During my externship, it was like one of the few times I, was actually on the floor and like implementing more nursing skills on my own. So during my externship, I was cleaning the room, and one of my coworkers told me what did she say? She was just basically telling me like to do a task, and I said, okay, got it. But I guess the way I said it, she may have misinterpreted my tone. And I heard, like, while I was near the room, and I heard her talking about me to her coworker. And I don't know, it just felt, it was a new experience for me, having like dealing with that, like, that kind of workplace culture in a gossipy environment. And I really thought about like, okay, is this the kind of place that I want to be in? Is this like a microaggression, like things like that? And yeah, I think more exposure to that type of topics about workplace culture and microaggressions would be a nice conversation in nursing school, especially as we go into practice.
Thank you for sharing your experience. That's tough. Because those externships really provide you an opportunity to choose and select your employer, and they to select you as well. Yes.
What I felt that they need to implement more so in nursing school is cultural responsiveness, the way of thinking, how to incorporate that in caring for patients of a diverse population. Working in an urban hospital in the city, it was an on-job training that I had to learn about. Not only is diversity, that's race or gender, but it's also religion, and it's different other aspects that makes up a diverse population. And sometimes it was challenging to take care of patients because of what was taught in nursing school, and to apply it, and knowing that you need an interpreter for those who speak of that has a language barrier, or if it's gender orientation, to be able to effectively care for the patient without bias. And so I feel that more implementation of cultural responsiveness is very valuable and should be more incorporated in the curriculum.
Thank you. Thank you. Shaneza.
Yeah. I feel that I'm about to graduate, but I feel that I need to learn how to separate my emotions and take care of myself, even though I'm taking care of patients. Here, I got enough training from my fundamentals and my med-surg rotation and most of the rotations that I've been to on cultural sensitivity, humility, and all those. And they talk about racism here. We are told about it, we're taught about it, and we're told that we will experience it. But you don't even know how you're going to handle it when you see it. You don't know how you're going to react when you see it. So when I talked about my OB rotation, it was very glaring. It was in your face. And I had to reach into my mature self to take care of that situation that particular day. So nursing school doesn't teach that. I don't know whether any nursing school can teach you that. It's something that you have to go into yourself to draw out on how to respond or react, and then know exactly why you're there in the first place. I came to nursing to be an advocate for people that look like me because of what I faced in my background. So nursing school doesn't teach that. I don't know how they're going to incorporate that, but I also have a good mentor who I always go back to. I send her text in the middle of the night and I'm like, I don't know how to go about this. Do something. And she comes back to me and she says, Chinasa, take a deep breath and, reach into yourself and bring this out. So if there's a way that can be incorporated, that would be wonderful.
Thank you. Thank you. You all shared some really sensitive experiences. And how would you say they've impacted your schooling or the way that you want to be as a nurse? How have they changed? Have they changed you? Have you swayed away from your drive to do what you want to do as far as becoming a nurse? And how did you resolve them? How did you resolve these issues? You know, Janasa, you talked about using your mentor.
When I started my fundamentals, I just knew that I can't do this without a mentor. I just knew that. So I reached out to one of my professors and I asked her, you have to mentor me. You have to tell me how to go through this. And she readily agreed. And she's been working with me. Even when I feel like I'm falling up, falling away, falling apart, I reach out to her and she's been a strong support system for me. Now, when I saw that situation at that particular rotation, first of all, I had to think about where I'm coming from. I'm a Black woman, a strong Black woman. If I say anything, this is what is expected of me: aggressive, bad, angry. I had to think about that first. I had to think about my family. I had to think about my mentor. I had to think about my son. And I took a step back. And finally, I had to reach into myself as a spiritual being and go, how am I going to handle this? If a patient sees me saying something that I shouldn't say, this is not a representation of who I want people to see me as. I came here for a reason. I have a purpose. And I'm not going to let anybody sway me. I also had to think about that I'm in Columbia. You know, my school will be disappointed in me. So I had to be a bigger person. There were so many resources, so many things in me that I had to reach into to draw strength from in order to do the right thing. Like I have learned from the people that are before me, from my mentor in particular, because she's always, I hear her voice, I hear her voice all the time, So reaching into myself and drawing strength from all the support system that I have was an outlet for me to walk away from that situation, and then represent myself, represent my school, represent my family, and then most importantly, represent us as a Black woman.
Thank you.
So some of the stuff that I had shared about not having learned in nursing school, a lot of that I learned on the job, being the need to assess implicit bias, especially coming from a place of privilege in almost every aspect of things, realizing how I come across to my patients and how I can best get them in touch with resources that they need in a way that's going to prevent them from having to come back in the hospital, since I'm mainly acute care based. And with that being said, I went into this doctoral program with the intention of being in the acute care track, but now I'm realizing with all these classes, I have the privilege of being in Dr. O'Connor's social determinants of health class. And that's been a huge eye-opener to all the things I need to do in the hospital and outside of the hospital to work towards better healthcare entirely. So to resolve all these issues I've come across, again, being an ally, trying to speak up about anything that I'm seeing, whether it's in the hospital, outside of the hospital, personal life, work life, surrounding myself with people who have different perspectives than I do and educating myself will go a long way.
Thank you.
For me, I am a representation of myself. I will not be like what I experience. That's my go-to. Just because you experience something in life doesn't mean you have to become it. It's a lesson learned. I show myself grace. I'm patient with myself, knowing that, it may not have been my fault, depending on the situation, maybe that specific person is not having a good day. So just, being understanding and, being mindful, thinking before you act, understanding that everybody thinks differently, reacts differently, different cultures, they believe in different things. And just, giving myself the grace I need and, understanding that the world is bigger than me sometimes. And I want to be the change in nursing. I do. I'm still passionate about it. I went into nursing because of my own personal experience. and no one would deter me from that.
Thank you. I hear a lot of strength from all of you.
Well, for me, my goal and my go-to is changing the narrative. Many times we are so easy to share our triumphs, but I'm also willing and vulnerable to share my defeats. And, you know, being in nursing school, I did have to take the boards more than once, more than twice. I've had to take it 3 times. And I feel like as an educator and soon to be faculty, it's important to show students that you are human and that you can bounce back. You have to self-advocate and to show that it is okay to be able to go beyond and still come out. And you're not a victim of your circumstances, and nothing shouldn't define what you're capable of doing, and always allow your work to speak for you. So changing that narrative of, you know, if I do this wrong, then that's it. But I want to show and be able, and just like the other representatives here, I'm very passionate about nursing. And though my journey was not easy, I'm very grateful for this opportunity. And I want to be that person, that mentor, that person to help, to assist, to change narratives of those students who feel like, you know, they can defeat the odds.
Thank you for your transparency and your courage to speak up and to share. Where you start is not where you end.
For me, I just, from what I've gathered from that experience, I'm just taking it all in, learning everything, like maybe things that I can do for myself, but also for other people, like for other future nurses. Trying, because I felt that unit wasn't too welcoming, what can I do to make it welcoming for others? You know, being more of an involved mentor, stuff like that, trying to create a path or open a new path for nurses like me, so we can have more of that welcoming environment in the workplace.
Thank you. Thank you. Oh, such a powerful panel. Khulud, you have a question.
Hello, everyone. Thank you so much for talking and bringing your perspective. And I just wanted to say something. I'm a Muslim nurse and nurse practitioner, and I'm currently doing my PhD in nursing. And I had several situations that I have been discriminated against, or because of my race and because of my religion. And I am hijabi, which means like I wear a scarf that shows my religiosity to the people. However, it brings more, I have been targeted because of my hijab. So one thing that I have noticed that brought me some kind of catharticism is using research. I have included religious discrimination into my dissertation, which is for Muslim nurses to bring their and to push for policies to support them. Especially, there is very limited research about Muslim nurses, especially here in the United States. And there is very little policies to support Muslim nurses. And especially we need policies to support us in our prayers, in our Ramadan month, and so many things that we need that. So I just wanted to say, like, try bringing that into research, bringing your perspective, bringing your community to push for policies, to push for advocacy for your community. I just wanted to add that point, and thank you so much.
Thank you for sharing. Be the change you want to see, right? Someone said that earlier. Where you start's not where you end. Be that inspiration. I think Susan B. Anthony used to say, failure is not an option. So what do you do for wellness and self-care? Nursing school is tough. The curriculum, the rigor of all the work, the assignments, the long nights of study, and then some of the things that you've described in the culture of the nursing program or the work environment or the clinical environment. What do you do for your wellness and well-being, self-care?
I can start. Me, I like to sleep. I make sure I get in a lot of rest. I like to watch TV, have me time. Just, it can be whatever, but as long as it's for me. So yeah, just doing things that make me happy. So watching TV, sleeping, and talking to my mom. I feel like that helps relieve some stress, getting stuff off my chest after a long day.
think they say we need 7 to 9 hours of sleep. I can remember a time that, we used to boast that, people only needed 5 hours of sleep and they could do so much, but it takes a toll on your body after a while. What else? Sleeps in the chat said 8 hugs per day.
For me, it's really been about finding my people, as Dr. O'Connor would say, including my pets. I have a cat and he makes a huge difference in just my mood around the house, because sometimes there's not time, if you will, for like watching TV or whatever you like to do. Unfortunately, as much as I try to do that, he's really there for just like an emotional support level of self-care. So that's huge. If you can have a cat or a dog, that's huge.
Awesome. Pet therapy,
For
yoga
me-
and meditation.
For me, also sleep. I do spa days quite often, and saying no to establish boundaries. I can't be a part of everything. So saying no is a complete sentence for me.
For
We
me,
do have, some of us have to learn that. Absolutely.
for me, prayer, 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 prayer. God has been at the forefront of this journey from the beginning until now, until the end. I pray to him all day, every day, and he has carried me through many triumphs. And I seek my mentor. She has been the backbone. She has carried me through the most trying times, my most trying times. And she has given me the courage to keep pushing forward, even when I said, I couldn't make it anymore. I can't do this anymore. This is too much for me. I have my son. He's my motivation. He pushes me. He's like 7 going on 17. So, he speaks very well to me and he encourages me. I have, a lot of different people that play different factors in my life. I also started regularly working out, exercise, journaling, and just meditation. Just, giving yourself that time, that quietness where no one is in the house, everything is off, and just sitting in silence. Sometimes you hear more when it's less noise.
Thank you for mentioning silence. I love silence and it's my go-to place. I use silence a lot. And I've also, in this particular journey, learned how to say no. I say no and I stay in silence. I find it very refreshing. And then when I come out of silence, the next thing I do is I watch a lot of C-dramas. And it's beautiful, it's pure, and it helps me heal. And then finally, I pray a lot and I do a lot of meditation. So when I'm going to take, like I have exams tomorrow, it's a med-surg. I'm going to be up all night to take that exam tomorrow. And thank you, Dr. GP. And once I'm done, Friday evening, I'm just going to shut my door and then stay in silence. And afterwards, I'm going to watch my C-dramas. It helps me. It helps me stay sane. Thank you so much.
Thank you. I want to thank all of you for being transparent, being brave to speak up and share some vulnerabilities. You all are going to be amazing nurses as you continue your journey. You'll do well on your exams coming up. You have the right recipe: rest, say no, quiet time, prayer, getting your people around you, all the great pieces of advice that we all can take and learn from. I'd like to ask one last question of all of you. Do you have a question that you would like to ask the participants tonight? Anything you want to ask or get guidance on?
Strategies can I employ to ensure a culturally sensitive and inclusive approach in patient care?
Excellent question. Any thoughts from the audience?
Say something, if you don't mind.
Dr. McIntosh.
For me, it all, to me, goes back to humanity and centering the patient, asking them about their needs, because they're going to know their body, their needs better than we are. So centering them, asking them the questions, they're the best author of their stories. So I would say that would be my takeaway or my, the tip for you.
Thank you.
I saw some things in the chat also. listening, being open, empathize with your patient, individualization, have your own self-awareness. Again, a lot of listening to the patients, yes.
And I would just like to add, being respectful of the individuals and living by the golden rule, treating others as you would have them treat you.
Thank you. Nicole.
And I just wanted to add, I think this was great. All the nursing students here. I didn't really know what I was getting myself into, but I just wanted to add, just make sure you stay involved, right? Participate in, certain organizations. You'll get to understand the different cultures. Like how we had our Muslim nurse that came up and brought up her, the concerns that they had. I actually took notes on that because it's something that I may have forgotten, right? So I think exposure to conversations like this are very important. Hi, by the way, sorry. So.
Thank you. Was that Omega or Nicole speaking?
That was Omega.
Okay,
earlier.
thank you
Hi.
so much, Omega.
Hi, thank you.
Nicole?
Yeah, I wanted to just add on to the golden rule. Someone once shared with me I believe it was the platinum rule, and an amendment to that would be treat people as they wish to be treated. So just to really think about that, my recommendation as an educator for new nurses would be to commit, even if it's just 5 minutes when you start your practice, to sit and be present with each of your patients. And there's no specific checklist, right? It's really just about getting to know that person. Depending on where you work, that person may not be able to speak with you. And so there may be other deficits involved in that. And if that's the case, then I would encourage you to feel and be mindful of what it's like to be in that space, even if you're uncomfortable, even if you don't know what to say. But I find that when especially with new nurses or nurses that are new to a certain specialty, that they acknowledge all these really special factors of the patient's experience. And maybe you were thinking about a care plan or a diagnosis when you came in, but you walked out knowing that this person just came from a country, or they were an immigrant, or they were practicing law, and you understand their frustrations because they can't speak now, so you'll find your own stories, but you'll make this really special connection and engender trust, hopefully. And the more people trust you, the more they will share with you. And the more they share with you, the easier your job becomes, because now you know. And the most important person that you can get information from will always be your patient.
Thank you so much, Nicole. That's great. Sandra Gale?
As I just want to mention that as a new nurse, it's not so much listening what your patients say. Most importantly, you also should try to listen what they're not saying. And it takes a little bit of time. That means you have to take time with your patient. It's not always about the task. Just by saying hello, you can detect a lot of things by how they respond back to you. So it's okay to listen to what they say, but it's very important to listen to what they're not saying.
Excellent point. Thank you so much. Well, amazing. Thank you to our student nurse panelists. Appreciate all of your insight and the dialogue this evening. I'm really proud of all of you. Keep up the great work. We look forward to you graduating and continuing to come back and visit with us. Let us know how you're doing. Tonight was amazing. I want to thank our speakers, Dr. Kenya Beer, Dr. Ashley Graham-Perrell, and Dr. Rebecca O'Connor. Excellent topics, excellent discussion. We learned a lot. Race is not biology. We have to discuss the upstream factors that contribute to disparities. We have to interrupt biases and false narratives. We have to be thoughtful of our history. The Lincoln School of Nursing, those 1,800 graduates that led the way for us here in New York, Mary Seacole and others. What have we learned from their journeys? How can what they've done impact, or how can we adopt some of the things that they did to impact healthcare disparities? Implicit bias, you know, those action steps that we're going to take over the next few weeks, few months, and have them become ingrained. We have to have intentional behavior changes, such as slowing down decision-making, practice perspective thinking, build respective partnerships. You know, when the evidence-based practice and guidelines are available, use them in every situation, just to name a few. And lots of insightfulness from our panelists. Health and well-being, speaking about, you know, how things and people make you feel. How are you going to take care of self? Really, really important. The importance of listening, of what's being said and what's not being said. But ultimately, we have some amazing future nurses here, and I want to thank you. I'd like to ask my colleague and co-director of the New York State Action Coalition, Deb Elliott, for any closing remarks. We have one last survey in the chat for the panelists. There.
Oops.
There you are.
Hi,
Awesome.
everyone. Hi, everyone. This was fabulous. I just have to say, it never ceases to amaze me how much I learn and how much I admire all of my colleagues across the globe, and love working with all of you on different levels. So thank you so much. And this was good information to take with us. Great takeaways. Thanks.
Thank you so much. And thank you, Jalen from Webistry LLC, for all your tech support. We will be providing a recording of tonight, and we will be sure to send that link out once it's been edited and available. Thank you again for all of you who took the time out of your evening to spend time with us and network. It's really been great. It's also awesome to see all of our colleagues from across the nation and internationally. We have some international participants tonight. So again, thank you all very much, and we will see you soon. Have a happy and safe 2024. Thank you.